When I'm surprised we are over this from the company. When I see the name of moderators, I have passed this phase of election and working on them. Priyankur is laughing, Monica is laughing, because they have really worked very hard for these days have gone.
Be ready next year again for all this.
I
The
know,
year
I
after
know.
next.
But that will be a different ballgame.
Yes, yes. It will be a different mindset. Yes.
Yeah.
Abhishek, are we live now?
Yes, ma'am, we are live.
Yeah, sure. You can start sharing the screen so that I can welcome everybody, please.
Yeah.
A very warm welcome to all the esteemed faculty members to the 18th episode of the Public Awareness Committee with the West Zone Societies. This month, we are focusing on menopause as well as antenatal screening because November is an antenatal screening awareness month and October was a menopause awareness month. So we have clubbed these two activities together, and we're very happy to announce that this is the 18th episode. And we are hosting this webinar on the second and the fourth Thursdays of every month with respective zones. Can we have the lamp lighting, please, Abhishek? We seek the blessings of Lord Almighty to Thank you so much, Abhishek. I would now invite Dr. Priyankur Roy to welcome all our faculties and delegates as the chairperson of the Public Awareness Committee. He is currently the president of WATOC, the only Asian to be. Welcome, Dr. Priyankur.
Thanks, Monica. Good evening, everyone. As she has already welcomed all of you, I again take this opportunity of welcoming all of you to this 18th episode of the webinar. And this has only been possible because of the active participation and support of all of you who are the faculties and the delegates who are present here today. So first of all, I can't start without thanking Dr. Rishikesh Pai sir, Dr. Madhuri Patel ma'am, Dr. Alka Pandey ma'am, who are the soul and pillars of this public awareness committee, and also Dr. Kalyan Barmade, of course, who is also the national coordinator of this committee. I would like to thank our coordinators and welcome them, Dr. Monica and Dr. Shatabdi, who has put in immense effort, and the conveners of the program, Dr. Vaidya Marathe ma'am and Dr. Monica Gupta ma'am. Our chief guest, Dr. Rishikesh Pai sir, and none other than Dr. Sunita Tandulwarkar ma'am. It's such a pleasure to welcome ma'am to this program, and I can see her very relaxed, very relieved, because this is, I think, one of the programs where she does not have the tension of, like the scientific talks, etc., and how it's going to pan, etc., and things like that. Because we all know that the way she talks is always brilliant, and being a chief guest for this program means a lot to us because we want to take her blessings for this program after getting elected as the president-elect of Foxy. Welcome, ma'am. I would like to also welcome our guest of honors, Dr. Parul Kotlawala sir and Dr. Asha Bakshi ma'am. Welcome, sir. Welcome, ma'am, for giving us this time and taking your time out of your busy schedule. I'd like to welcome Dr. Vrinda Joshi and Dr. Vaidya Marathe ma'am once again as the chairperson of the talks, and also Dr. Kiran Kutkoti sir and Dr. Monica Gupta ma'am as the chairpersons. We have two brilliant speakers with us, Dr. Prashant Acharya sir, who's going to talk to us on antenatal care, recent trends in India, and Dr. Anju Soni ma'am, who is not able to join us for medical emergency. The talk is on menopause and HRT. We'll see if we can pitch in with the talk with someone else over there. The panel discussion is on AUB in perimenopausal age group, and our moderators are Dr. Gaurav Mandrupkar sir and Dr. Meenu Agarwal ma'am. Again, brilliant moderators, and I'm sure we're going to learn a lot from them in this session. The expert is Dr. Suvarna Khadilkar ma'am, and expert panelists are Dr. Rashmi Khahar ma'am, Dr. Sujit Kondar, Dr. Renu Setia, Dr. Aditi Rathod, Dr. Shabna Sultan, Dr. Monica Singh, Dr. Sunita Wadhwani, Dr. Darshan Wadekar, Dr. B.S. Jodha sir, and Dr. Bajrang sir. So I welcome all of you to this platform, and also welcome team Corona Remedies as well. And I hand over this platform back to Monica to kindly take through the inauguration and also the scientific session.
Thank you, Dr. Priyankur, for the welcome note. I would like to invite Dr. Sunita ma'am as the chief guest for the program. Madam is the president-elect right now. Can we have Madam's slide, please, Abhishek?
Okay, still he puts up the slide.
Yeah.
I think I'll
Yes.
introduce ma'am. She is, of course, the president-elect of Foxy. She has been the president of IAG. She's going to be the president-elect of, she's the president-elect of ISAR as well. She has headed most of the organizations, and she is a pioneer researcher. She has been the pioneer in stem cells, pioneer in laparoscopy. Name any department in OBGYN, and she has been a pioneer and she's a leader in that field. It's a pleasure to have you with us, ma'am. Your smile is quite charismatic, and we can see that already. So I welcome you to kindly bless all of us in this program.
Thank you. Can we have a close-up of this slide? Please close down. Let me have
Stop
all
sharing,
my
Abhishek. Yeah, thank you.
Stop
let
sharing.
me
Yeah.
have all my friends with me here. So first of all, thank you, Public Awareness Committee. Priyankur, very dear to my heart, he knows it. And his programs always are very well thought. And the way he has worked as a committee chairperson, helping to all the presidents of Foxy is commendable. And that's why I think he became a president of some world organization for the youngsters who can, what is the name, Priyankur, that?
It's
Is
called
Vato.
WATOG, World Association of Trainees in Obs Gynae.
It is for resident
trainees,
doctors.
residents. So, see, till he became a president, I was not aware that there is an organization like that. That is where when we don't even know the organization, he became a president of that organization. That's what Priyankur is. And Monica, I'm watching you for last more than, I think, 2 years working close association, not only with Priyankur in public awareness, but even for announce. You come out always with a novel program. And I'm very, very happy. And I hope to see you one day in Foxy as well. Parul, our guest of honor, who will be taking over in Hyderabad as a chairperson of ICOG. We congratulate you, and we are looking forward for a wonderful ICOG. I think the ICOG, the way Mandakini, the way Lakshmi Srikande, they have taken it to the level. I'm very sure, Parul, knowing your academics within your genes, I know the ICOG will have a great job, and looking forward to work with you. Meenu Agarwal, our own president of Pune OBGYN Society, along with Gorak, I think is going to moderate the session. And being a very dear friend, I'm always there to wish her all the best for whatever endeavor she wants to go in. We have our Vice President Foxy, Asha Bakshi here, and I think the rest of the people are little bit busy. But Monica, when I say Monica, it's the convener Monica and the Monica Singh of Bhopal, both. Both of you are my amazing friend. I found huge talent in you. And Monica, whichever post you go in, whether it is a Foxy, whether it is ISAR, whether it is a Bhopal OBGY Society, I'm sure you will be doing a justice to that organization. When I see the scientific program, Monica, you have designed it beautifully. Menopause and HRT, antenatal care recent trends. Instead of writing all the time inverting pyramid, when you got Prashant Acharya as a speaker, I'm sure he will come out with all the recent trends, and he will talk not only about the first trimester, but he will go beyond the first trimester. I'm very sure about it. So I wish you all the best for this program, and thank you for making me a part of you all. Thank you, Monica, and thank you for your reminders all the time. Thank you.
Thank you, ma'am. Thank you for blessing us. I would like Priyankur to introduce Parul sir as well. Abhishek. Priyankur?
Monica, you can introduce her, please.
Yeah. We welcome you, sir, as the chairperson-elect of ICOG. Sir has been the professor and head at the Institute of Medical Sciences, Ahmedabad. He has been the vice president of ISOPAB in the last year, a chairman of the Education Committee of the South Asian Federation of OBGYNs, the coordinator for the NESA, as well as the IAS. We welcome you, sir, as the guest of honor, and we request you to please give your blessings.
Thank you. Thank you, Dr. Monica. It is indeed a pleasure to be part of this very important activity of Public Awareness Committee, and I compliment Priyankur and the team for having so many webinars. This is number 18, correct? So hats off to you people. And I see that the program is so well designed. You have menopause and pregnancy care and the transition from reproductive to menopause, perimenopause. And I'm sure Prashant will go beyond ultrasound in antenatal care. And why it would be really interesting to listen to what he says. And I think Dr. Soni will not be here. Otherwise, she is an authority on menopause medicine. And the panel is very elite and one of the mega panel. I have not been part of any panel with 10 panelists. I'm sure because of the virtual nature of this webinar, it is possible. Otherwise, your stage would be full with 10 people sitting there and 2 moderators. I do not go.
Sorry to interrupt, sir. One thing, just the AICOG, I just received session for this Hyderabad AICOG and 2 moderators, and they have put 12 panelists in that. So I was a little surprised there is a physical
But
thing.
in their
But then,
heart,
yeah,
they
I think
know
most of them
that
might not come. Most of them might not come. That's why.
4 may not come. That would be in
Yes,
their
exactly.
heart.
Exactly. Thank you so much. Yes.
Okay. So it is very, I mean, I'm missing the president and secretary of Foxy here, but president-elect makes up for the entire thing. And I would not go into taking names of all of you, but it is indeed always a pleasure to be interacting with you. I did tell Dr. Monica that I have some other commitments and I may not be with you for a longer period of time. And I'm going to miss some very interesting presentations. So I think Dr. Asha will take care of all that. Thank you very much and wish you a very good webinar. Thank you.
Thank you, sir. Thank you for joining us and sparing your valuable time. I would now take privilege in introduction of Dr. Asha Bakshi, madam. Madam is a lead consultant at Dr. Asha Bakshi Fertility Center in association with Motherhood Hospital, Indore. She is currently the Vice President of the West Zone Foxy, and we've had a very great conference at Indore, ma'am, because of you. She has been the Treasurer of ISAR, a member of the AICCRCOG West Zone Executive Committee, the Founder Chairperson of MP IIG and MP ISAR. She has been also the past Chairperson of the Foxy Infertility Committee, the member of the ICOG Governing Council. We welcome you, ma'am, and we request you to please say a few words.
Thank you very much, Dr. Monica, for the kind introduction. And I would like to thank Dr. Priyankur Roy for conducting the whole program under the Public Awareness Committee. And the whole program has been selected so well. And so nice to see Dr. Sunita today. Under the leader of Dr. H.D. Pai, all the programs are going on very well. And this is the beauty of webinars, that even just before Diwali, we are still doing the academic sessions and still not missing out much from the time from the family also. So otherwise, it's really difficult during the Diwali time to take out the time for all these educational activities. But Foxy has great enthusiasm, and so has Priyankur. And I would like to congratulate Priyankur for his latest achievement. And so nice to see Dr. Parul Kotrawala here as well. And Dr. Meenu is there, Dr. Prashant Acharya is there, and Monica Singh is also there. And so it's really nice. Dr. Jodha is there, Dr. Sunita Wadhwani. So all of you are there, and this program is going to be very good. And especially there is a lot of effort which has been put in by Dr. Monica Umberpant, who is the convener of this program, and Vaidehi. And I'm sure the topics, you are all waiting to listen to all the topics rather than this discussion. So I would just wish you all the best. And I think you should just get going. So thank you so much once again for the invitation.
Thank you so much, ma'am. Priyankur, are you there?
Yes, Monica.
Yeah, you want to give any concluding remarks before we conclude our inauguration so that we can start with the academics?
I just want to thank everyone for joining here. especially Sunita ma'am, Parul sir, and Asha Bakshi ma'am for the wonderful blessing that you have given us. Thank you so much. We would request you, if your time permits, to kindly stay on with the academic session and put in your inputs if possible. If not, of course, we understand you're busy. If not, it's absolutely fine. And thank you so much once again for joining us. Thanks a lot.
Thank you, Priyankar. We can now move ahead with an academic session. Monica ma'am and Vrinda ma'am, both of you are there. So I will introduce both of you. You can then introduce Prashant sir. Abhishek, can we have Monica madam's slide and Vrinda Joshi madam's slide, please? Dr. Monica Gupta madam has been the past president of Alvar OBGY Society, and she is the West Zone coordinator for the Public Awareness Committee. She is active in most of the public awareness activities of in and around Rajasthan. She has been the Foxy Achiever Award of the West Zone Yuva Foxy at Ranthambore, and she is a Dhira Master Trainer and the Manyata Assessor. Ma'am, we welcome you as a chairperson for this session. I would like to introduce Dr. Vrinda Joshi madam as the next chairperson for this session, please. Can we have madam's slide, please, Abhishek? Yeah. Dr. Vrinda Joshi madam is a senior gynecologist from Gajraram Medical College at Gwalior. She has many awards and publications to her credit. She has been the trainer of online training of medical officers on maternal health. She is a state trainer of the cervical cancer screening and CIN programs. She is also the chairperson of the Mahila Yaun Utpidan Shikayat Evam Anmohan Samiti, the member of the medical board for termination of pregnancy, the trainer of comprehensive abortion cares, as well as a medical teacher for the last 20 years. She's also the National Ethicon Traveling Fellowship she's received. Ma'am, we welcome you as a chairperson for this session. And we request you to please introduce Prashant sir. Vrinda ma'am?
Yes, yes.
Yes, ma'am.
Please put the slide for Prashant.
Yes, ma'am.
At the outset, I am very much thankful for inviting me for this very informative talk and very a galaxy of elegant speakers. So about Dr. Prashant, he is a medical director and chief consultant of Paras Advanced Center for Fetal Medicine at Ahmedabad. He has been honorary fetal medicine consultant at SVP Hospital at Gujarat University, Ahmedabad. And in ISCOG Fellowship Award, he has been a board member and trustee. He has been an ambassador to Asia and Pacific region, ISCOG International Faculty of Speakers, first Indian to be honored, and ISCOG BIDS Committee. He has been an ISCOG Advisory Board member since 2012.
Madam, it will take a long time. I think we should go to the talk straight away. It will take...
yes, I think that's a better suggestion because there are so many feathers in his crown that it makes a big crown.
No, it's not like that. But I wish we will use that time.
Yeah.
Right.
So,
Thank you, I'll share my screen. So can you allow me to share my screen? And somewhere,
please, sir, please share.
So I'll share my screen.
Yes.
Can you see my screen now?
Yes, sir. We can see. Yes,
yes.
Perfect.
Thank you very much. This is my CV as such, but I think let us go to the main talk. Antenatal care in 2024. I have written 2024. What we should do and what we should think about next year, how we should plan the antenatal care in upcoming year or upcoming time. So this is the scenario which happens. So it doesn't matter how many resources you have, and if you do not know how to use them, they will never be enough. Look at this gentleman. He has got so many staircases in front of him, but still because he tried to peep in through the wall. This is the exactly scenario. Even when you have got a good basic ultrasound, good antenatal care, still you don't follow them, then this is the scenario. As an obstetrician, yes, I totally agree. We have our two fingers, works like a stethoscope, and a stethoscope to listen, and a good two hands to examine the maternal abdomen. But 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 if you have a machine capable of doing a reasonable 2D imaging and a Doppler, you should use it appropriately for antenatal patients. Without ultrasound, I don't think today's antenatal care is going to be adequate or enough. So how many times life is like this picture. You have the resource, but you make the poor decisions. So a machine is lying in your consulting room or in your hospital when you don't use it appropriately. And this is the scenario where I will never wish that I'll end up in any of the scenario. A pregnant lady comes to you. I want to evaluate the fetus. I do a scan, a good quality scan to look at a fetus. My eventual aim is to have a good, healthy mother and unhealthy child. So in 20, this is all possible because of the invent and I think advancement of ultrasound quality machines. I think someone has to mute themselves, please. Someone's mic is on, so if you can mute yourself.
Yes, sir. Muted, sir.
Yeah. So that is if I have to consider that way. So before 2020, I have just written a word antenatal care before 2020. What we do in our antenatal OPD, this is a typical pyramid is being followed once in first 3 months, then every month, then every 15 days, and last month we call her every week. That is one of the absolutely I'll call it as not useless, but a kind of unnecessary, excessive antenatal care where there are many examinations where we don't do anything. Say, for example, 24-week scan, 28-week antenatal examination, 16-week antenatal examination, we don't do anything. Just put our hand on mother's abdomen, we may measure the weight and the blood pressure, job is done. Actually, we don't do any decision making. As an consultant, we should have a visit when we are going to make certain decisions. So there are 3 scans which we usually do it in before 2020, 11 to 14 week, 18 to 23 week anomaly scan, and the last time as we try to look for the growth and Doppler. This is all I'll call it's a past now. Because why I'm saying is Kipros has turned out with an inverted pyramid that one at 12 week, one at 20 week, then collar at 39 week, which is not going to happen in India. Because this is not acceptable in India. You call a patient right, you could just come after 4 months of your 4 months from 5th month of pregnancy. It is not acceptable because we miss so many things. So what we have come out is we have published a paper in the White Journal and a conference that it's a tube of pregnancy care now. Scan at examination and scan at 3 months, where we do a good examination at 13 week. We do early anomaly scan. We predict preeclampsia. We predict preterm birth. We look for multifetal pregnancy. We look for a chorionicity of the pregnancy. And because both managements are different, we try to follow that up. So your preterm birth prediction with aneuploidy risk prediction with NIPT now or without NIPT, depending upon your circumstances. The next examination has to be at 5 months, where at 23 weeks scan, we do biometry anomaly scan, a good detailed basic neurosonogram, a basic fetal echo, 8 soft markers. We measure cervical length by transvaginal scan. We predict preeclampsia, and that's how my scanning has to be, and the evaluation has to be at 5 months. Then at 7 months, we have a very, very peculiar thing which happens at 7 months, because at 28 week, late developing anomalies, we can pick it up. We can counsel them when to do, how to examine. And then there is an entity called early fetal growth restriction. And we as an obstetrician should precisely know what this early fetal growth restriction is and how to deal with that. One important point is placenta accreta spectrum. Because the previous section rates are now, seasonal section rate is almost 40, 50, 60% now, depending upon the center. A previous section with an anterior low-lying placenta, where I am worried about placenta accreta spectrum, and that is what I will try and evaluate at 7th month of pregnancy. And a 9 month, I would be interested in looking for late developing anomalies, but late developing fetal growth restrictions, I would, because here the classic Doppler cascade will not work, and I would also like to do a placenta accreta spectrum evaluation at that time. For fetal heart, the same thing is applied, because at 3 months of evaluation, a major cardiac defect which are non-compatible with life, I can evaluate, I can rule out. At 20 week, I would be able to, 22 weeks scan, I would be able to diagnose the small little congenital cardiac issues. And if still the termination is possible, so you can go on that side. If they want to continue, you can investigate for the genetic association. At 7th month, some of the cardiac defect like cardiac block, coarctation of aorta, critical aortic stenosis, they will pop out. So they will come out at that time. And at this time, you can, with the other malformations, you can probably refer at appropriate center that, okay, look, you should go to the center for the delivery. So again, a time and place will be planning for a peripartum care, which will be decided at the 9th month whenever you are looking during the pregnancy. So there are baseline 5 segment when you are evaluating 11 to 14 week scan: dating, aneuploidy, detailed anatomy, cervical, and then uterine. So look for 5 segments. If you are, as an obstetrician, if you are not doing scan, make sure that whosoever you have referred, they come out with these 5 separate segments to you. And aneuploidy, as all of you know, that you have to look for the nasal bone, you have to look for the nuchal translucency, and then that is what is the and ductus venosus, and then you calculate the risk and whether what is the scenario, how much is the risk for aneuploidy. If you have, as an obstetrician, if you do not know or you don't have a software, I'll give you one very simple rule by which what is normal nuchal translucency. I'll tell you. You have measured a CRL, just prefix 1. If you have the CRL is 60, then 1.60 is a median normal value of your NT. Okay, if it is 74 of CRL, 1.74 is a median NT. Say, for example, instead of 1, if this prefix figure is 2, you need NIPT. Say, for example, you are evaluating at the 60 CRL. So 1.6 is a median. 2.6 is at 95th centile, you need NT or NIPT. And if it is a 3.6, you need invasive testing. So just remember these rules, you will have a crystal clear decision making, and you don't have to rely on anyone else. So what we do is for aneuploidy prediction, if the risk after doing ultrasound, if the risk is more than 1:200, we do CVS. If the risk is less than 1:1000, we don't do anything. But in intermediate risk, we offer self-repeated DNA. Double marker test is dead, and then we never offer double marker test because there are a few reasons. There is a limited role of double marker in the era of NIPT, and there is limited role of double marker for in era of PLGF for preeclampsia also. So we don't do double markers. Very, very rarely use a double marker, but we go for self-repeated DNA. That is 2024 antenatal care, and that is what you should be thinking of. Now, and the early second trimester anomaly, just remember figure 1, 2, 3, 4, and 5. So there are 5 biometries you should be looking at: CRL, BPD, HC, AC, and female length. That's what a biometry. This is the list of anomaly sections which you should be taking, because that's what is going to be 2024 and the assessment of the fetus. Just simple one section. The 2 mid-sagittal sections, there are a lot many. This is absolutely normal. This is absolutely abnormal. You can have much detail. But the prime section is going to be your nuchal, this NT segment, where you can diagnose so many things: nasal bone hypoplasia, the forehead which is there depressed or it is protruding out. You can diagnose palate. You can diagnose the lip. You can diagnose the absent corpus callosum. You can diagnose open spinal defect, increased nuchal translucency. You can have many things which you can diagnose. A palate is easier to diagnose, and you should be looking for these 3 dot sign for the palate evaluation in your upcoming scan. The heart, of course, 3 vessel view, 4 chamber of the heart, abdominal circumference. That is one of the basic thing which is going to be the future of the first trimester scan, because you can diagnose so many things just by doing a 15-second. A basic CVS, as I told you, you can have right from side, abdominal circumference. I'm showing you the various mode: slow flow, HD flow, color flow. You can look for the fetal heart in the first trimester. That is going to be a routine antenatal care, and this is the arch of the aorta. Arches, you can look for the arch of aorta, all 3 branches. That beautiful images you can have. Now, the aim of first trimester scan is there are a couple of things. Always detectable means you should be able to detect, even in court of law, if you have missed any ecrania or locoencephaly, you will face trouble if you have done the scan. undetectable, you can't detect. So I'm not worried about these two segments. But in the recent era, those potentially detectable, I'm just listing the malformations which are potentially detectable. You should think about how can you make this is detectable, and these are the things which, if you convert from potentially detectable to detectable, that is what is going to be required in upcoming time, and that is what is going to be a recent antenatal care as far as the first trimester is concerned. So what should I expect from my first trimester examination? Ultrasound in first trimester used for dating viability, diagnosis multifetal pregnancy. Aneuploidy assessment by NT, NB, DV, and TR plays a small part in aneuploidy assessment in the era of NIPT. I can predict that NT scan is going to be dead in upcoming 2 or 3 years. It is not going to be early NT scan, it is going to be early anomaly scan. So my primary aim is going to be not NT. It is an early anomaly which are not compatible with life. I would try to evaluate those. So that is my prediction. That's what is going to happen. Detection rate of aneuploidy after new algorithm will be more than 99% if you use your NIPT. All little malformations which are not compatible with life can be evaluated. Where a routine anomalies can be 55%, early cardiac assessment should be done. Early CNS assessment is going to be possible. Preterm birth prediction, because the cervical length is essential. Look for the uterine artery Dopplers. You can start aspirin if it is more than, the PI is more than 2.5. In the mean uterine PI is more than 2.5. What we call as an improper placentation during the first trimester, because still you have got a second phase of placentation is pending, where you can help by giving these aspirin. So, and of course, in multifetal pregnancy, diagnose of monochronic versus dichorionic, and that is what is going to be new after 2021, and that is what I would put it across in upcoming 2024 antenatal care. Next scan, it comes at the 5-month, where there is a full list which is going to be available. But in nutshell, I would put it this way, that there are 8 segments: 1 biometry, anomaly, echocardiography, aneuploidy, cervical length, uterine artery, look at a placenta, and look at a liver. So these are the total 8 segment everyone has to evaluate. And these 8 segments, if I want to take care, I would put it across just like all the sections, just like this. And I would like to put it across that, okay, I will be looking at a biometry with these 7 points, CNS for these 3 sections, cardiac for these 4 sections, 8 for my aneuploidy screening, a cervical length by transvaginal scan only, a preterm birth and FGR prediction by doing uterine artery Doppler, also preeclampsia and FGR by a uterine artery Doppler, placenta and Leica. The basic biometry, I would like to put it across, but you should have a very precise sections and precise measurement, and that is how I would like to put it across. And I would like to tell you one thing, that if you know the basic ultrasound section, basic ultrasound plans, then your evaluation is going to be easier. This is a basic scan about the fetal biometry, the basic second trimester scan for the fetal brain, a posterior fossa when you try to evaluate the cerebellum. But now this is everyone is doing. But I would like to add that in 2024, it is going to be a mid-sagittal section of the brain, where I look for these corpus callosum and I look for the vermis. Okay, so this is a 2024 addition to my examination. I would like to tell you one thing, that a role of volume imaging in fetal brain evaluation is phenomenal. You can evaluate the brain just beautifully, but it's not beautiful. It's about my diagnosis is going to be much better, and that this is what I will expect. So use of 3D volume imaging with an high contrast, or what we call as a VCI, is going to be the key for upcoming 2024 evaluation. A spine evaluation, why I am showing you a spine? Because the spine, that is going to be one of the important point, because all spinal defect, this is a 3D volumes, you can evaluate the spine beautifully. Now, why I am showing you is that there is one good reason. This was a meningocele which was diagnosed, but what we could see that, okay, the cord which is here, and there is a CSF which is lying posterior to the cord near the skin, and this means the cord is not tethered, so outcome may be good. And this is exactly what happened. The patient continued the pregnancy, and baby was operated, and this is the scar, and now baby is almost around 3.5 to 4 years. It can walk. Everything is normal. So all spinal defect may not need a termination. It needs a good profile evaluation and then examination. A face profile, of course, it is not for the face. For me, it is for the nasal bone. It is for me, it is a pericallosal artery. For me, it is a corpus callosum, and for me, it is this vermis evaluation. That is what I can see in that fetal face. So I will not go in the stepwise evaluation, but I'll give you a very overview what you should be asking or you should be doing in your 2024 week screening of your antenatal care. A basic 4-chamber view, situs evaluation from abdominal circumference, 4-chamber, 3-vessel, and 3-vessel trachea view. I want just gentle sweep from abdomen to the upper part of the thorax, where you can see everything, and that is what I will put it across. That even if you have got these 3 basic sections like a 4-chamber view plane, then even if you have got a 3-vessel trachea view or a crossing of the section, intraventricular anatomy crossing, 3-vessel and a 3-vessel trachea view, your diagnosis is correct. More than 80%, you will be able to identify fetal cardiac defect. So that this is what I have just put it across in front of you, that these are the malformations will be diagnosed by you, if you are doing just 3 basic sections. New volume imaging can give you some phenomenal images. I totally agree. But if you use it, then you can have some beautiful, unbelievable images which you can always have if you have got a volume images just like that. Moving for the next, the section is aneuploidy evaluation. You should be looking for these aneuploidy. Look for the soft markers, because this soft marker evaluation definitely will give you a lot of age in your evaluation, and you will be able to calculate your risk for trisomy 21 in your report. 2 in head is borderline ventriculomegaly, nuchal fold thickness. 2 in the heart, aberrant right subclavian artery, echogenic cardiac focus. 2 in abdomen is spilectis, is an echogenic bowel, and 2 bones is a nasal bone and a short femur. So 8 malformations, 8 soft marker you should be looking at, and look at these negative and positive likelihood ratio. You will be able to calculate this like this. Now coming to last section of this second trimester is cervical length. Look for the length of the cervix, that is right. But also I'm just adding one point is look this length after the fundal pressure test, because these kind you may occasionally have these incompetent Ross, and it may open, which was previously 27, where you may not do anything, but after fundal pressure, it remains 14. So I always put it across that always do evaluation and intervene. Like what? Whether you are comfortable with ostatin, you can go. If you are comfortable with progesterone, you can give. But make sure that you intervene at least when the cervical length is 25 millimeter of length, because that is a 10 centile and it gives you a genuine reason to identify. Now, prior history for preterm birth is important. Watch for the length at the first trimester. If missed, look at the length in the second trimester. Look at a progressive shortening. 4 millimeter shortening, then your last examination in a month, it is heading towards your preterm birth. Look for the funneling. Look for the fundal pressure leading to shortening or funneling. Then you can have progesterone or cerclage as per your choice, but you should have a low threshold for intervention in multifetal pregnancy. A uterine artery Doppler in second trimester, this is all because of the physiological changes, because of what we call the placentation. The uterine artery and the branches, the myometrium will get resorbed, and the artery become like a venous locules, and you will have a low resistance flow instead of high resistance flow. That is what is known as proper placentation. And these proper placentation, you know that when you have got a proper placentation, the uterines will have a good diastolic flow, and these good diastolic flow will tell you that, okay, it has got a resistance after the point of interrogation is low, and you have got a good placentation. We have made it a thumb rule like this, that in first trimester, any mean PI is right and left, take a mean. If it is more than 2.5 in first trimester or 1.75 in second trimester, it is what you call it as an improper placentation. And this improper placentation takes you to a complication called PIPIP, that is like preeclampsia, IUD, prematurity, and IUGR, and placental abruption. It has got more than 97% negative predictive value. So if the uterines are normal, this lady is not going to develop these complications. So that is what I would put it across. You can add on PLGF or you can add on PEP-A for your better evaluation, or you can, if you find it is as an improper presentation, it is a role you can start aspirin, but there is a role of low mercury aspirin when and as and when required. That is what is a thing you should be looking for. Now coming to next segment is 7-month scan. I am interested in the rest of things we have evaluated, but when you find your lower segment ballooning like this, when Nita Bush layer, there is no differentiation between the myometrium and the placenta, or vertical vessels, when you have got a vertical vessels going towards the bladder, think about placenta accreta. The easiest thing to look for is the bulging of lower uterine segment. That is important. Look at these vessels going, which is crossing 90-degree. Look and think about placenta accreta spectrum, and that is where you should be worried. Coming to 9th month, I think I have got still 7 minutes. I'll finish up by this thing by that time. Fundal height, I know which very few of us we use the fundal height by taking a measurement, but there is a role of fundal height if it is falling 4 centimeters short, that you can think about fetal growth restriction. But now fetal growth restriction is diagnosed by two systems, only AC and abdominal circumference, or with an addition of a Doppler. If abnormal Doppler is there, then you call it as a growth restriction. But in India, we take it like it is only AC or expected fetal weight, which is smaller than 10 centile. We call it as a growth restriction. But nowadays, now the entire system is changed. See, look at this year. This is 2021. This preeclampsia definition is absolutely different. Now, we used to call more than 140/90, it's a preeclampsia, pregnancy-induced hypertension. If it is associated with proteinuria, we call it as a preeclampsia. This is a traditional definition, but the 2021 is AGOG, American Journal of OBGYN. They have, along with an association with International Society of Study of Hypertension in Pregnancy, what is known as ISSHP, they come out with 3 more additional factors. One is association with a maternal factor, so maternal factor plus fetal factor, maternal factor, fetal factor plus angiogenetic factor. These angiogenetic factors are nothing but the PLGF and some placental anomalies. So let me put it this way. So I'm just showing you the complete graph here. So the recent guideline, you have got a proteinuria, you may have headache, you may have visual symptom, you may have right from eclampsia, blindness. These are also all pleasant platelet count, abnormal platelets, abnormal creatinine levels, or abnormal the hepatic enzymes, or when you have got a fetal growth restriction setting, or IUD, or uteroplacental insufficiency, all comes under the category of preeclampsia. So now the preeclampsia definition is different than what we had till yesterday, I think. So because there are many reasons for these fetal growth restriction, I won't go into detail, but make sure that you use your Indian biometry, because Indian biometry, it will give you quite a lot of additional information. But when you use your biometry, make sure that it falls about 10 centile, because there are very few biometries which you will get 10 centile. This is our biometry, which we have come out, Indian biometry, by us only, Prashant. We have published this biometry, which is accepted globally. If it is falling below 3rd centile, they all are growth restricted. And same thing is with your expected fetal weight. If it is above 10 centile, that is normal, but it falls below 3rd centile, they are below 3rd centile, they are all growth restricted babies. And that is what I would put it across. But here there is I would put it as there is a clutch there. There is you have to draw a line at 32 week. Any growth restriction happening before 32 week, or any growth restriction happening after 32 week, they are all defined as early growth restriction and late fetal growth restriction. That is true for abdominal circumference, and that is true for even expected fetal weight. If the expected fetal weight falls below 3rd centile, that is growth restriction. early growth restriction, and after 32 weeks, it is called late fetal growth restriction. Now, because fetal growth restriction, I'm just giving you the definitions, and this you can read from the reference. This is ESWOG guideline. But I would like to tell you one thing. The primary difference is because of the mechanism or the problem which are really very different. So what happens during your the transport, when the mother's blood comes into the space and it goes into maternal vein? So SpO2, which was 100, it has gone down to 45. But umbilical vein, which drains from the fetus, umbilical artery drains from the fetus, takes the blood to the placenta for the membrane exchange. And when it comes, it has got a P2O2 21, but when it goes out to umbilical vein, it is 35. So it carries the oxygen. But when in case of growth restriction, the placental villi are less, and that's the reason the less number of exchange which happens. So you have got less villi, that means architecture is at fault. Umbilical artery will have increased resistance because you have got a less number of vascular architecture. Uterine artery will have increased resistance because of the same reason, and eventually baby will develop hypoxia, and baby will react to this hypoxia by brain sparing effect. In late fetal growth restriction, the problem is not the placental villi. The problem is in the membrane. The membrane is not working. It's not allowing the oxygen or glucose to transport, and that's the reason you will have a normal resistance of uterine, normal resistance of normal PI. Umbilical artery will have low resistance, normal PI, but still baby will have a lack of oxygen, which is going to happen, and it will lead to redistribution setting. Once you have got a redistribution setting, you can evaluate by either by doing a Doppler or computerized cardiotopography. NST has got no role whatsoever, so forget about non-stress test. It is a computerized CTG or the Doppler. So it is when to do what. So eventually, because it is all about the redistribution of the entire system, and the left outflow, if throws blood out, 10 will go to the heart, 60 will go to the brain, but remaining 30 will go to the descending aorta. If the right outflow tract throws 100 ml blood, 10 will go to the lungs, but 19 will go to the ductus. So totally in descending aorta, 120 ml will go, but from that only 25 will go to the lower limb, and rest of the 95 will go to practically to the placenta for exchange. I'm giving you an example. That means half of the complete cardiac output will go to the placenta for exchange. So whenever there is some problem, this entire system will lead to redistribution, and you will find it like an increased resistance from forward flow to reverse of umbilical artery. And in middle cerebral artery, what you will find is probably practically you will have instead of this, you will have a high resistance flow, and instead of high resistance flow, you will have a low resistance flow. That is, you will find. You can calculate the CPR, but I know you can calculate the CPR, but for me, it is the one of the important point is going to be the aortic isthmus, which gives you quite a lot of information, and this aortic isthmus gives you a much detailed information about the fetal dilatation. Ductus venosus is the vessel to evaluate. If ductus venosus is bad, that means you are talking about the severe fetal hypoxia, and that is where it is going to be the practically the dead fetus, which is because it will end up in a CCF. So this is a classical cascade which is going to be followed up, and there was a stage-based classification which was suggested by Greta, but after 2017 everything has changed, and it's not to be utilized for sure, because the ESWOG has come out with the new guidelines, and these new guidelines I can show you. This is a complicated graph. Let me make it simple for you. For delivering in India, because classical cascade, it will be followed in early fetal growth restriction. Wait till there is no forward flow in diastole in umbilical artery, or wait till you have got ductus venosus is 0.95. So simple thing is one, absent in diastolic flow in umbilical artery or ductus venosus, if it reaches to 0.8, that is at 95th centile, wait till this time. If at all you have reached to any of the scenario, deliver the child. And in case of late fetal growth restriction, it is the classical casket which is not being followed. So the management is different. And here it is, as I told you, it is the membrane which is at fault. And because membrane is at fault, the umbilical artery will have a normal resistance. And that is exactly the reasons, because the brain will sense the high PO2. And that's the reason the first change you will expect is in middle cerebral artery, then it is CPR ratio, then is the umbilical artery, and then is the ductus venosus. So this is the decision making as far as your late growth restriction is concerned. Now, let me put it across just in nutshell. If CCTGA, if you have the computerized CTG with you, then you should be thinking about in a system where you can just wait in case of 32 week or less. Your trigger for delivery has to be this 5. If it is more than 32 week, you should have a trigger for delivery of these 7 points. If you don't have a computerized CTG with you, don't worry. Your number of triggers will be reduced. You have got the triggers which, if your computerized CTG is not available, and if it is 32 week less than gestation, then trigger for delivery are 2. Ductus venosus more than 95th centile, or absent or reverse in umbilical artery. More than 32 week of gestation, the trigger for delivery is these 4. MCA less than 5th centile, CPL less than 5th centile, ductus more than 95th centile, or absent or reverse umbilical artery. Never exceed 39 week of the gestation. And as I told you, the once you have diagnosed fetal growth restriction, your journey starts. Your road is a good antenatal surveillance by Doppler and a growth velocity. And this is how you should be looking at. You should be looking for the Dopplers and your decision making for this growth restriction is, again, as I told you, these are the factors. And my ultimate destination is long neurological outcome at the adult life. Now, what is the antenatal care in after 21? This is what we have already discussed, but what the additional advantage? For the mother's antenatal profile, this is a standard. You can add on, delete something depending upon your requirement. But TSH with free T4. That is with free T4. Don't do without that. For previously affected fetus, appropriate index case evaluation, please get it done. Some genetic tests, if required for the previous child, make sure that you evaluate them appropriately. But for the fetus, it is, if you do it what I said, that you can improve the aneuploidy detection, early anomaly detection. You can improve early severe preeclampsia prediction, preterm birth prediction. This is what, as an obstetrician, you want. So all in all, there are many things for mother and fetus in upcoming in 2024. You should be expecting and you should be doing. Thank you very much for patient hearing. And thank you, the team of Foxy and Priyankur, for inviting me here. Thank you.
Thank you, Dr. Prashant. It is rather a very technologically sound antenatal care. And I hope that all our next obstetricians will be following everything, understanding things, and making antenatal care as simple but as vivid, illustrative, and predictable for everybody. But at this note, I would also like to share something. Like I am in Madhya Pradesh, and even simple antenatal care, like as you said, a doctor putting their hands on the abdomen of the woman, is not obtained by large number of women, and that's a huge mammoth task ahead.
Sorry, I totally disagree with you, because even any of all hospitals, or I would put all PHCs, all CHCs, you have these many facilities are available. So in that days in India, they are all gone. That antenatal care is not available. Sorry, but I totally disagree with those points. I think because I really mean it, that it is application of ourselves to the situation. They can always refer to an appropriate center. There are free centers, free government medical colleges. They can always get a scan done, at least 1 or 2 whenever possible. Get your blood test done. That is also can be easily done. There are things which are possible. You have to decide, okay, I have to do this. then it will be all done. Without that, it won't be possible. I can guarantee you that.
Thank you. Thank
Yeah.
you for this.
Mm. I think somewhere even I partly agree with Dr. Vrunda and also with you, Dr. Prashant, that there has to be a will, of course, that is the thing. But the thing is, the people who have the will, they move to bigger cities, and the smaller cities sometimes do lack some facilities like a 3D.
We would like to, we are thinking about future. So we don't want to be
in future, yes, I agree with you. Yeah, that is the
all
future.
those excuses aside, we try to find out what's the solution, how can we help them.
Absolutely, absolutely. Yes.
So initially, we can have a from the PHC high risk patients can be transferred, and later on the awareness will increase. And initially, the sonography was also not evident. Now people are going for 4 or 5 sonography during the pregnancy. Initial days, hardly 1 sonography used to be done, and later on, as awareness increase, I think the investigations and predictability of the complication will also increase. Even in the small centers also.
That is why this is the public awareness committee. That is what you are doing an excellent job in that. Yes. Correct.
Thank you, Vrunda ma'am, and thank you, Monica ma'am, for judging. Neenu ma'am, for your comments. Prashant sir, it was an exhaustive talk, and I am sure all the delegates have had a very good take-home message after that. I would like to Dr. Monica madam to introduce our next speaker, Dr. Shobna Mohanty ma'am. At the first instance from the Public Awareness Committee, ma'am, we want to thank you immensely for accepting our invitation at the last moment and joining us for this webinar right now to give a talk about HRT. I request Monica ma'am to please introduce madam now.
It's my immense pleasure to introduce Shobna Mohanty ma'am. She's a consultant gynecologist and laparoscopic surgeon at Sun Medical Center, Thrissur. She was a past president IMS, past president IMA Thrissur, past general secretary Quiz chair and West website chair. And she has organized various endoscopic workshops, and she is a South Zone coordinator of Foxy Hysteroscopic Workshop in 2011. Ma'am, please, we are waiting for your talk. Over to you.
Ma'am, I will just speak because I think madam is not unmuted. In the meantime, Meenu ma'am, can you discuss with Prashant sir with the take-home messages from his lecture? I will just call up ma'am immediately.
Surely, surely.
Yes,
Dr. Prashant, are you around? Dr. Prashant, are you around? Okay.
Ma'am, I think you can give a take-home message if she is not there.
Prashant sir has left.
Okay. Shall we start with the panel first and then you can have the next talk? Is that okay? By the time they are setting it up? Dr. Gorakh is also here. I just spoke to him.
Ma'am, just give me one minute, ma'am. Just give me 1 minute. Yes, ma'am.
Surely.
And the take-home message for the antenatal care is we have to diagnose whatever possible in the antenatal period, because the obstetric, as it was an unpredictable branch, and with increasing diagnostic techniques, I think it is becoming more and more predictable. We can diagnose many things before if we are little bit aware of it. So the awareness among the obstetrician is also important before we are going to aware the patients. Like the placenta accreta, when we are land up into it, it is a really havoc. And if we diagnose it early, it will be very helpful for us. A simple sonography is going to help you out a lot. If we are not going for the MRI and all these things, I think we should learn how to do a proper sonography.
One very important thing is that as obstetricians, we cannot tell the patient that everything is good with you.
That
That
is.
is very, very important, not only from a medical legal point of view, but also for your own satisfaction and for patient satisfaction. Patient comes to you thinking that I'm going to the gynecologist or the obstetrician, and that person is going to tell me if my baby is fine. We have to tell them that this is a teamwork. I can only see that the baby is fine, the heartbeat is okay, but whether the baby is anatomically normal has to be seen by a fetal medicine specialist. So that information should go to the patient, and we should not, the obstetrician should not take all the load onto themselves, saying that the baby is absolutely fine. So, because there can be anything, even in the first trimester, you can pick up. Sometimes you can't pick up in the first trimester, second trimester. The other day, I had a patient, the third trimester, it was picked up, and very, very difficult to explain to the patient. So, if you have a team, a complete team talking to the patient, it is always better. So, don't take the complete award, the accolades, and also the, if there is a brick batting, then also you're sharing with someone. So
But we gynecologists should also have a very good knowledge about the sonography.
how to
I think
read.
Madam has joined.
Yes, correct.
Welcome, Madam Shobna Mohente. Ma'am, please share your slides.
And I was the chairperson for imaging science for from 18 till last year, and I learned so much. There is so much in fetal medicine. Now it is, I think, a special branch by itself. So obstetrician should know basic ultrasound, how
At
to read
least.
ultrasound, how to understand the Dopplers, when to intervene, when not to intervene. But because every city, like Dr. Vrinda said, fetal medicine specialists are not available. That is a little bit of a challenge. So, keeping that in mind, I think the obstetrician should understand, should try to learn at least the basics of fetal medicine. Yeah.
And Madam,
Thank
they
you.
should have at least knowledge to interpret the report also.
Right.
Yes,
Many
ma'am.
times report is also there, but the obstetrician is not able to interpret that, and that it becomes a little bit difficult.
Right.
Thank you, Monica ma'am and Meenu ma'am. We have Dr. Shobna madam here. Shobna madam, thank you immensely for joining us at the last moment and accepting our invitation for this talk. I would request Monica madam to reintroduce madam in only a few words, because madam
No,
has
no,
just
that's
joined
okay.
back.
Doesn't
Yes,
matter.
ma'am.
Anyway, I'm standing. So nobody has come listening to my CV. They just want to hear the topic. So I will
Sure,
start my
definitely, ma'am.
topic.
Ma'am, you can please.
1 minute. I have not done slide share. I'll do that
Yeah.
first.
Abhishek, please allow ma'am to share her slides.
Yes,
No,
ma'am.
I have to put on the slide share on the PPT. No, that I have not done.
Yes, ma'am.
I'll do that first.
Thank you so much, ma'am, for chipping in the last moment. We are very, very grateful, ma'am.
No, no problem at all. Priyankur has called me. So I said, okay, fine, I'm free. So I'll do it. No problem.
Yes, ma'am. Just make it full. Yes, ma'am. Perfect.
How many minutes? You please tell me when I should stop. I don't remember how many minutes this PPT was.
Ma'am, the talk is usually for 20 minutes, ma'am, but
Okay, so I'll try to rush through it. I don't remember that it is 20 minutes PPT or 25. I don't remember now. It's long back. So anyway, so MHT is generally is given for the hot flashes. The main indication for MHT is hot flashes. We all know it is a feeling of warmth. It happens in around 50% of women. That's the newest study that I'm conducting now, all India. Although they say 85%, we have had pan India results. Even 50% is too high, because South India, we are all getting just 25% in our data. But somehow the all India data is showing 50%. So every 2% will have it, at least in North India. That's what the study is coming. It's being written down, the new study. The hot flashes basically come because of fluctuations in estrogen levels. And once it reaches a nadir post-menopause, somewhere around 60 plus and all that, then you don't get hot flashes. It's when you get into menopause, either before or after that, you get your hot flashes. That's because the fluctuating estrogen levels confuses the hypothalamus, and so, it doesn't know how to put on the thermostat. So the person starts feeling hot even before the thermostat should be on. So it's little confused. And so when a person comes with hot flashes, you can't give, drugs. You can't just say take some diet and all that. When they're really bad, you have to give drugs. And the mainstay is either estrogen alone in a woman who's hysterectomized, or estrogen progesterone, or tibolone, which is a selective tissue estrogenic activity regulator, or basidoxepin, which is tissue selective estrogen. Uh, yes. So now, the doses: microgen and micronized estradiol or conjugated estrogen. Micronized estradiol is 1 or 2 milligram. Estradiol valerate is 1 or 2 milligram. Conjugated estrogen is 0.2625. The best progesterones are the micronized progesterone, but they are costly. The age-old ones are MPA, 5 milligram for cyclic, which is the last 12 days of the month. You have to write it down for the patient. So the cyclic is 1 to 25 days, you give your estrogen, and the last 10 to 14 days, you give your progesterone. Rest of it, I won't read out because it's a short presentation. So, this is just conjugated estrogen is from the horse's serum. 17-beta estradiol metabolizes to estrone, estriol, and estrogen sulfate. Estradiol valerate is a very old one. Now this ethinyl estradiol, this is what is there in OC pills. It is a very hatta-katta estrogen because it has got alpha ethinyl group. It prevents the oxidation of the 17-beta hydroxyl group. So it will not get hydroxylated fast, and it will remain there for a long time. So it's going to be, it's got 4 times more potency than your conjugated estrogen or estradiol or valerate or whatever you have. That's why you will get a DVT with your OC pills, but you won't get a DVT with your conjugated estrogen or valerate or whatever. Estriol in our student days, it was there, but nobody ever gives it for MHT anywhere. So, to reiterate, 1 tablet of conjugated estrogen, you have to take 4 tablets to equal that of 1 COC. Therefore, in women who smoke, obese, have migraines and hypertension, you are allowed to give your normal MHT, but you are not allowed to give your COC. So, you have to remember that. Now, transdermal MHT for all the patients with cholesterol and things like that, because it does not modify the markers of coagulation. It passes the liver and everything. It is more consistent. It doesn't have to go through 16 foot of the gut. So it can directly enter the blood circulation. So we do have sprays and creams. The creams have to be applied on the hand, and it has to be left for 5 minutes. But the spray will get absorbed very fast. But of course, the spray is little more costly. The Lenzetto people have got the spray, and the Intas people have got the ointment. The infertility people are also using these things. So it's all available in the market. If you want to give your Ambanis or whoever has got enough money and who don't want to get into trouble when they have got cholesterol and things like that, you can afford to take your sprays or ointments. It will 1 tube will last 26 days. So classical symptom of hot flash is not a inherent health hazard. So people are not willing to spend so much for it. That is the main problem. If you say you've got cancer, they will spend for it. If you've got something else that will make them die, they will spend for it. But for hot flashes, why should I spend such a big thing? That's the general indication. But the real indications for transdermal are triglyceridemia, where if you can afford to spend, migraine, diabetes, controlled hypertension, existing gallbladder disease, obesity, smoking, varicose veins, etc. Progesterones are generally an integral part of menopausal hormone therapy if the uterus is intact. Even that's becoming rare these days, of course. But if the uterus is there, the endometrium should not get a hyperplasia, and so you have to give your progesterone. The doses are MPA 5, Dihydrogesterone 10, micronized 300. That's pretty high, no? So these are the doses. Basically, it's the progesterone which stimulates the lobular system, not the estrogen, which only stimulates the duct system. And most of the cancer is in the lobular system. Therefore, progesterone causes breast cancer, and therefore, not the estrogen. And so, the breast-friendly progesterone should be given. And they are the better. That's why you have to spend more on your dihydrogesterone or micronized progesterone, because they are most breast friendly. But all said and done, and you also get a better sleep with natural progesterone. You have your antenatal patients, you give them a little bit of micronized progesterone. They say, "Doctor, I'm feeling so tired." It is a fact, and we may or may not diagnose it because we say first trimester they are not, they are anyway tired. No, it's actually progesterone does make you feel tired, you know. Yes, the WHO trial is the death knell of all MHT earlier. That's because most of the patients, they started getting stroke, breast cancer, infarction, increased risk. That was because the study was done on 60 plus women. And in the 60 plus women, what is the difference? At age 50 to 59, the blood lipids are improved. But once the plaques are already formed, the prothrombotic effect of estrogen will add to the already formed plaques, and then you will have those plaques going into your brain or heart and causing heart attack or stroke. That's why it's a problem. The younger people don't have those plaques already formed. So by itself, estrogen is good in the younger women, but in the older women, you can't do that. So if a 60-year-old woman comes to you and one day and say, "I've heard of MHT, I went through the net, please give it to me." No, you can't give that late. She should have come earlier to you. But even if for osteoporosis, if you want to start MHT, not after 60, not after 10 years, you have to stop at 55 years or more than 10 years after menopause. Suppose you have your menopause at 50 years, then maybe you can give it to a 60-year-old woman. That's how it is. But after all, this fear of cancer is actually overplayed, and only after giving EPT for 4 years you can get CA breast, you know. EPT does not appear to initiate malignant transformation, only to potentiate it. In fact, if you have a cancer, it will show it out faster. Otherwise, you wouldn't have known there is a cancer. And how many women actually take EPT for more than 4 years? Once their hot flashes are gone in the first 3 years, they don't take it. So all this cancer with progesterone or whatever is actually overplayed. So the point is that the evidence says that after 5 years use of estrogen progesterone, you will get 8 extra cases per 10,000 women. So wouldn't you be in the 9,222? My maths is bad, but you are just 8 in 10,000 extra. Is it such a big risk? I don't know. The risk of getting associated with long-term estrogen use is really much lower than the risk conferred by obesity, inactivity, and alcohol use. You are willing to do all that, but you're not willing to take your MHT, saying you'll get cancer. But what are the side effects of cancer? This MHT, as a practitioner, you should know that it can cause GI symptoms, painful tingling and swelling of the breasts, endometrial bleeding. That's say you don't use your pad for a long time and suddenly you start reusing it. They're not very happy with you. Headaches may increase. They stop with menopause, but it may increase. And after 78 weeks after MHT, you can even get inflamed pancreas, and you'll think it is appendicitis. You'll forget you've given MHT. Liver function checks can be affected. So these things should be there at the back of your mind when you prescribe it. And dry eyes, anybody has got dry eyes, cannot be always MHT. Increased deep vein thrombosis. I already told you can't take COC and all that, but there is increased deep vein thrombosis even only with MHT, not just COC. So such things can happen. So how do you know which is at fault? If there is breast tenderness, reduce the estrogen. If it's irritability, depression, reduce the progesterone. Because water retention and headaches, you have to reduce the progesterone or change the progesterone. So this is, again, you can restrict salt intake, cut down on caffeine and chocolate. Who takes chocolate anyway otherwise? So fluid retention and bloating, you can't wear your blouses anymore, your dresses are becoming tight. Switch to a low dose transdermal estrogen. and switch to a low dose progesterone, switch to a micronized progesterone. Mood changes, you can actually change over to Tibolon. Okay. And progestin also you can change over to an LNG-IUS. So you don't have to go on taking every 14 days. No? Put in your LNG-IUS, give estrogen, that's it. So you will have less of the side effects. You can take estrogen at night, lower the dose if there is GI symptoms. Now we come to genitourinary syndromes where recurrent UTI, recurrent dryness, and recurrent pain. There you can use vaginal creams, either conjugated estrogen. It's applied for daily or even estradiol, which is not really available here. Estriol is the one which is commonly used, but nowadays it's not there in the market, at least in Kerala. The dose is 0.5 to 1 gram daily for the first 2 weeks, and then weekly, twice weekly, and then weekly. And the safety data is there for 2 years. You don't have to substitute progesterone. Because the dose of estrogen given in the vaginal one is so low that you really don't need progesterone added at all. And so that is the dose again repeated. Now, conjugated estrogen again vaginally depending on the severity. Estriol cream, 1 applicator full of cream. Now let's go on to Tibolon. People say, I feel tired, I don't have sex drive, and my husband has got a sex drive. So shall I take estrogen? No, estrogen won't give you the sex drive. You have to give Tibolon. It's, actually in 1942, all this estrogen was marketed, and then it caused bleeding. Then they started progesterone. Then the progesterone started getting cancer. So they needed a drug which will give you, reduce the hot flashes, won't stimulate the endometrium. And then after 25 years, they found this Tibolon, and coming to the market, it was 2004. So what is Tibolon? It gets converted to estrogen, androgen, and progesterone. So you have 3 in 1, So you don't have to take progesterone supplementation. Everything is there in that one particular tablet. And it will reduce flushing, it will reduce bone resorption. Everything that estrogen does, it will do. Plus androgen effects like improving sleep, prevents the loss of muscle strength, improves lean body mass, decreases proliferation of breast epithelium. In fact, if you want to do a mammogram on a woman with estrogen, the mammogram will change because the estrogen changes the breast architecture. But when you're giving a patient Tibolon, the breast architecture won't change, and then you can get a good mammogram, That's the difference between the Tibolon and that. And the sex drive can also improve because of the androgen. But the lipid profile is almost the same, lowers the levels of HDL and lipoprotein levels and all that. But status of cardiovascular protection is really not known. Dose is 2.5 milligram per day. It's better to start 1 year after menopause, because if you won't have abnormal bleeding, then they won't blame you for the drug. That's a smart way, So, but if it is there, you have to reassure them that it's as long as it's not excessive and as long as endometrium is not more than 5, really you don't have to worry. It just doesn't matter. At least you're getting rid of your hot flashes. So you have to caution them, teach them about starting it after 60 years, because estrogen can't be started. It's not the same. The indications, contraindications, it's all the same for estrogen and Tibolon. You can't start after 60 years, whether it is Tibolon or whether it is estrogen. Yes, it may decrease for body fat. So dieting, some sort of, it's easier, Increase the fat mass and total body water. Weight gain should not be a major concern. But when there's symptoms of insomnia, nervousness, disinterest, androgen deficit syndrome is there, Tibolon can be a good option. It has shown itself to be superior to conventional HT in women with surgical menopause. All those people where you are knocking off your ovaries because egg free. Knock off the uterus, knock off the ovaries, and then they'll come right back to you with hot flashes. And there you can use your Tibolon. It can be an alternative to conventional HT for the treatment of postmenopausal women with sexuality changes. So, other reasons, benefits, with MHT. You started for hot flashes, but the extra benefits that you get is less joint pain and stiffness. You can get onto the stage faster, get down faster. Preclinical studies suggest that possible benefit is there in preventing muscle loss. So you want to open a bottle, you ask the younger person to do, you don't have to do that. If you take your MHT for hot flashes, you can open the bottle without the help of a youngster. Obesity and weight gain decreases, and reduction in colorectal malignancy and neutral effect on lung cancer. So how long can you use premature menopause? Up to the natural age of menopause. Natural menopause, the safety data is there for 3 to 5 years, for God's sake. And after that, who wants to take it anyway? And with estrogen only, safety data is there for 7 years. So don't get scared of MHT. So very severe hot flashes, mostly 5 years is enough. But please do follow up the patient 1 month, 3 months, 6 months. Look at the weight, blood pressure. Look at her as a patient. Look after her. 6 monthly, do her lipid profile, hormone profile, clotting profile, breast examination, mammography, all that. 2 to 3 years, as you would do for any person. Pap smear, mammogram has to be done every 3 years. But whenever your woman comes with hot flashes, please don't jump to a conclusion because it's the easiest thing to diagnose. It can also happen if a patient is on calcium channel blockers. Every alternate woman is taking something like that for hypertension. Diltiazem, niacin, raloxifene, clomiphene citrate, nitroglycerin, calcitonin. If a woman has got serious diseases like thyrotoxicosis, you may be the first one to diagnose it. You think it is hot flashes, but it may be thyroid problem. That's why you need to examine a patient properly, So there can be other instances of hot flashes also, where you just pop MHT to the patient, but she's actually suffering from something else. COVID, you had to be careful. These slides were made during COVID time. Anyway, bazidoxifene is the next one. It's not available here. No, it's actually a selective estrogen receptor modulator, and it's a tissue selective estrogen complex. It retains the efficiency of estrogen, but does not stimulate the endometrium or the breast. So it's one up on the progesterone, so you don't need to give that. So you give 0.45 milligram of estrogen. That will take care of your hot flashes. You're not giving it 0.625. So you're lowering the dose of estrogen. The side effects of estrogen will be less. And you add to that this bazidoxifene. So both together, hot flashes will be properly dealt with. You won't get breast cancer. Your bones are solved, looked after. And so it's one up on the conventional MHT. But it's very costly. So yeah, it's still coming. Now, again, everybody asks this question, premature menopause, young girl coming 40-year-old, what is the difference between HRT and OC pills? I already explained. The OC pills has got 4 times more estrogen. And if possible, you are supposed to use the MHT and not the OC pill. But yes, it's easier to give COCs, young girls, so what if you give COCs? I wouldn't say it's absolutely a no-no. So what about diabetes? MHT is definitely it can decrease your glucose levels, decrease your fasting insulin. It can reduce your obesity. So it's definitely allowed to give MHT in diabetes, but do not give in unexplained vaginal bleeding, stroke, TIA, MI, pulmonary embolism, breast of endometrial cancer. We have a lot of breast cancer survivors who are coming there. If they're estrogen receptor positive and they really have real bad hot flashes, many of them are on letrozole for lifetime. And they will beg you to give them estrogen. But yeah, it's better to give them venlafaxine or something like that because you have to find alternatives. Cholestasis and hepatic adenoma, SLE, there is an increased risk of flares, porphyrias, you won't even diagnose it. It's actually a condition where you'll have abdominal pain, chest pain with all these rashes. And it won't come to your mind. But if that patient has got that, then you can't give MHT. Can exacerbate the attack. Endometriosis, even if you knock off the ovaries, there are endometrial implants around, So you have to give your progesterones. This is one patient where even after hysterectomy, you have to start giving progesterone. Or you can give Tibolone. Because otherwise, it's like creating premature menopause. So you have to give it. And you have to give it up to the natural age of menopause. Even in fibroids, basically the fibroids may increase in size, but what happens is after you stop the therapy, it will come back to the same size and it will not cause symptoms. So this is the study that they have done, that in the third year, the increase was not marked and it doesn't affect the patient. So you are really allowed to give MHT even if she's got one or two fibroids. So you don't have to really do a hysterectomy for a patient with hot flashes if she comes with fibroids. Of course, it's easier for us to do the hysterectomy and give MHT, but studies have shown that it's not necessary. So the risk of getting cardiovascular events is definitely reduced with estrogen therapy. That's what the Framingham study has shown. In hypertension, it's not a contraindication to be MHT. There is a study which has studied, they have actually done the 24-hour blood pressure testing. I don't know how can they get so many women to study, I don't know. But they have been testing them 24-hour BP and they found that the BP, 19 such studies have found that there was no effect on BP. And some studies even said that it's even improving the hypertension. So as long as you're not using COCs, MHT is definitely good for hypertensive women. But just because heart failure is there, it's not a contraindication, because in the study with patients who were having heart failure, they divided them into two groups, and one group were taking MHT, the other was not taking MHT, and the ones who were taking MHT, lesser number of people had died. That is 21% died. In the other group who were not on MHT, 34% died. So there is definitely no contraindication, but primary indication to prevent CVS, you should not be giving it. So far, HRT given in a perimenopausal women can be good for the heart. HRT is safe. HRT started for the first time in a woman more than 10 years postmenopausal can be detrimental. Hysterectomized women more than 55 years. Again, you can't start after 55. Lipid-friendly progesterones are better to use. And suppose I had a patient with diabetes and sepsis, and diabetes was not getting controlled, and she had cholesterol also. And she was going on saying it's all because of the 2 centimeter subserous fibroid. She had hot flashes. Here, estrogen and progesterones were prescribed, and she was rich, and that was much better. And your diabetes can be controlled much better once your tensions are gone, Migraine generally reduces after menopause. But if you want to give HRT with hot flashes, you give a continuous regimen instead of giving a sequential regimen. That will be better, because absence of variations of hormones is necessary, because it's the variations that cause the migraine. And if you give a continuous regimen, the variations won't be there and you will be okay. Even in migraine, you can try it out if she's really badly symptomatic. So, irritable bowel syndrome, you can have irregular absorption. You never think of it, no? Why the patient is getting irregular bleeding? She's on antibiotics. She will have poor absorption of drugs because of increased motion. And then she'll come with irregular bleeding. And you will forget that she's having cough and you have been giving her antibiotics. So all these small things also can be there. Thrombocytopenia, warfarin, how many women are on warfarin? All these people, if you give, irregular bleeding can be there. So this again, antibiotic, I told you, intestinal hurry. Asthma, there is a small increase, but no worsening of pre-existing disease. So anybody on inhalers can take MHT. Parkinson's disease improves, but only for that you can't give. Renal failure, you can give. And post-bone marrow transplant, they are all going to be increasing in number all these days. And they are all really having hot flashes, and you may be called to give it. Post-renal hepatic transplant patients are also going to be there. Rheumatoid arthritis is another place where you are going to be called in. Thyroid disease is not contraindicated, although thyroid, level decreases when you are on MHT. So I think I'll stop here, because either you're getting bored or I've exceeded my time. Anyway, thank you for this short duration of a talk.
Thank you, ma'am. Thank you for your excellent talk. At the last moment, You accepted our invitation and we are highly thankful to you for that.
Thank you, Dr. Monica.
Thank you so much, ma'am. Thank you, Dr. Monica, ma'am, and thank you, Vrunda, ma'am, for sharing the session. Ma'am, it was indeed an exhaustive presentation, and I am sure the delegates must have had a very good take-home message from this. I would now request Shatabdi to please carry on with the next academic session.
Thank you, Monica. Thank you, ma'am, once again. It was indeed a very nice lecture, and thank you for accepting our invitation last week. Thank you so much, ma'am. Yeah, we'll now move on to our next session. Our next session is a panel discussion on AUB in perimenopausal age group. We have two excellent moderators and a very good team of panelists with us. Our two moderators for the day are Dr. Gorakh Mandrupkar sir and Dr. Meenu Agarwal ma'am. Dr. Gorakh Mandrupkar is an IVF consultant at Angel IVF Clinic, Wakad, Pune. He is also the Vice President of Gestosis India Association. Welcome, Gorakh sir. Meenu ma'am is the President of the Pune Obs-Gynae Society and the elected Secretary General of the International Society of Gynecological Endoscopy. She has various awards to her credit. Welcome, Meenu ma'am. Our expert for the panel is Suvarna ma'am. Suvarna ma'am is the Professor and Head of Department of OBGYN Consultant at Bombay Hospital, Institute of Medical Sciences at Mumbai. Ma'am will try to join, but I guess she is in a meeting at Hyderabad, so she might not be able to join. However, we're looking forward to her joining. Welcome, ma'am. Our panelists for the day, we have 10 panelists with us. Firstly, we have Dr. Rashmi Kahar ma'am. Ma'am is the organizing secretary, has been the organizing secretary of AMOGS 2020. She's also the secretary of the Amravati Obs-Gynae Society. Welcome, Rashmi ma'am. Our next panelist is Dr. Sujit Konkar. Dr. Sujit Konkar is a practicing consultant at Aurangabad, and he is also the chairperson of the Fetal Medicine Committee of AMOGS. Welcome, Dr. Sujit. Our next panelist is Dr. Renu Sethia ma'am. Ma'am is the director of Bombay Hospital and Maternity Home, Hanumangarh Junction. Welcome, Renu ma'am. Next is Dr. Aditi Rathod ma'am. Ma'am is the consultant at Rathod Nursing Home. Ma'am has also been the organizing team at AMPOGS 2018, faculty at various secretary national and state conferences, and the secretary of ROGS. Welcome, ma'am. Next is Dr. Shabana Sultan ma'am. She is the professor in Department of Obs and Gynae at GMC Bhopal. She has presented various programs, various papers in national and international conferences. Welcome, Shabana ma'am. Next is Dr. Bajrang Lal sir. Sir is a professor and head at Government Medical College, Shikar. Also the president of the Shekhawati Obs and Gynecological Society. Welcome, sir. Next is Dr. B.S. Jodha sir. Sir is a senior professor in Obs-Gynae, of course, in Dr. S.N. Medical College, Jodhpur, Rajasthan. And he has various awards to his credit and is the secretary of JOGOS. Welcome, sir. Next is Dr. Darshan Wadekar. Dr. Darshan is the president of the Surat Obs-Gynae Society and a gynecologist and a fetal medicine specialist at Surat. Welcome, Dr. Darshan. Next is Dr. Sunita Wadwani ma'am. Ma'am is the president of Ratlam Obs-Gynae Society as well as the director and consultant of Ratlam Hospital and Research Center. Welcome, Sunita ma'am. Last but not the least, we have Dr. Monica ma'am. Dr. Monica Singh ma'am is a professor at LN Medical College, Bhopal, consultant reproductive medicine at Bhopal Fertility and Endoscopic Center, as well as the honorary secretary of the MP ISAR, MP chapter of ISAR in the year 2023-24. Welcome, Monica ma'am. I now hand it over to Meenu ma'am and Gorakh sir for carrying out the panel and looking forward to an excellent discussion. Thank you all.
Thank you, Dr. Shatabdi. That was very nice the way you presented everyone. Thank you so much. I will share my screen. So just give me a minute. Okay. Can you see my screen?
No, ma'am.
Yes, ma'am, we can see, but it's a white screen.
No, ma'am. Not seen yet.
Click on next.
Can you see it?
No, actually you have shared the white screen, not your presentation.
I'm sharing the presentation.
Yes, stop the presentation once and ma'am share it once again, please.
Okay. All right.
Ma'am, can I stop share from my end?
Oh, yes, you have to stop share from your end. Maybe that is why I'm not able to share.
Yes. Now try it once more, ma'am. Yes, ma'am. Make it full screen.
Great. Perfect.
Ma'am, we are seeing that iCloud storage screen, not your presentation.
Oh my God, why like that? Okay. All right, I'm sharing again.
It will come. Till then, I welcome all panelists.
Thank
you. We are actually, it was a last minute invitation, so was not prepared, but whatever prepared, we are going to present in front of you all. And we are going to discuss today mainly the abnormal uterine bleeding in perimenopausal age group. And we all know there are 3-4 important topics.
Madam, not we are seeing the same screen.
Okay, I'll log out and log in again. Sometime that works. Give me a minute. Okay, give me a minute. I'll log out and log in again.
Okay, like Mangal Mission. Mission Mangal. Right. So till then, we'll discuss that. Yes, there are a few issues we all know, and we have tried to present only 3 cases. And in those 3 cases, we will try to cover the whole abnormal uterine bleeding in the perimenopausal age group. So let Madam join.
Sir, we missed you at Ratlam. We were wanting
you to actually, I was going to come, but I was on 13,000 feet.
Whenever you are comfortable, we'll be loving to, have you here in Ratlam.
Definitely, yes. I was fortunate that I was there at Annapurna Base Camp.
Ji sir, we saw your recording from that place, and it was we could feel the temperature out there.
Right. Just today morning only I have come.
Ji sir.
And yeah.
Girish sir happens to be my senior. He was immediate senior to me in my college times.
Great. So may I request Dr. Jodha sir that sir, can you just please just give the brief information how many cases we are nowadays looking because you have a great seniority. So what is the percentage that previously what was the perimenopausal abnormal uterine bleeding, and is there any change nowadays in the perimenopausal age group AUB? So may I request Dr. Jodha sir. Sir, unmute please. We are not able to hear you, sir.
Voice is coming?
Yes.
Yeah.
Yes,
so nowadays we are getting good number of cases because of patients' awareness. Previously, the patients were suffering there. What type of medications available in their vicinity, whether homemade preparations, whether quacks, and every sort of practices are there still in the area in which we are residing is still practice, and we are getting these patients in 3 grams and 4 grams and 5 grams reaching to us just taking some jadphonk and tabiz and that, like this is because of some God's disgrace. So these are the situation, but the educated people, they are reaching, or the peripheral centers which they are having their access, they are reaching to us because of referral. They have tried many sort of preparations available, like hemostatic they have given, injectables they have given, hormones they have given, still patient is in trouble. So these cases are reporting to us in form of various structural problems of AUB, or there the facility of sonography is there, getting some abnormal structural problem in form of polyps, fibroids, or like that, or abnormal architecture of uterus. So these patients with sonography report are reporting to us, and So the number is good, because still we are getting 15-20% of our OPD patients who are coming any sorts of irregular form of bleeding, whether which may be other younger patients or in even perimenopause age group patients.
Right. So I think sir has rightly pointed out that the incidence is almost same. Only thing is the awareness has increased, and that's why the number of patients who are attending these AUB OPDs. And as sir has rightly said that the treatment modalities, diagnostic modalities are now easily available, and that's why we are feeling that KRA problem is increasing. But sir has rightly pointed out that yes, it was there and it will be there. So we have to be very careful about it.
Sorry, excuse me. When I'm sharing the screen, it is only sharing the white screen. I don't know why. Is there some?
Madam,
should I
have
start?
a backup. I have a backup. Can I share on your behalf?
You can do that, but I'd made some nice changes.
Oh,
So
yeah.
everything. So let me
Actually, Dr. Meenu has she has added so many good videos for very interesting presentation.
Yes, though.
Yeah.
But why is it showing whiteboard? I don't know.
Madam, you can just mail your PPT to the person. He will share for you.
Yeah,
that
but
can be done.
will not get the
Abhishek, you already have the
Videos
PPT with
will-
you. Please
yes,
share
ma'am.
it, no?
Yes,
Okay.
ma'am. I have shared to ma'am also.
Monica madam, only problem is the changes which Dr. Meenu has done.
So
She wanted actually in those. That's
they
why.
can be
Otherwise, I thought
enumerated
so.
and
So, ma'am, you can just share it to Abhishek. He will share the
Right.
slides with.
Right. Till then, we will have the discussion.
Yes,
Dr.
yes, sir.
Sunita madam, may I request you?
Meenu ma'am, I am share. You can comfortable on WhatsApp or mail, ma'am. Meenu ma'am.
No, I am comfortable on WhatsApp also.
Yeah,
so,
ma'am. So I am sharing my number.
No, but my presentation is on my laptop, so I'll have
Oh,
So,
okay.
ma'am, if you can mail him, he
Mail
will
it
share
to
his
me
email
if it
ID
is
right now.
possible.
Right. Videos may not go, but I will share
Right.
it.
Yeah. Till then, we'll have. So, Sunita madam, do you think that the incidence of adenomyosis or fibroids is increasing nowadays?
Yes, sir.
Or,
We can.
right. And what can be the reason?
Adenomyosis was never diagnosed before because it used to be diagnosed. It used to be a post-operative diagnosis initially. Nowadays, we have sonographies which can tell us that adenomyosis is there. And lately, the gynecologists are doing sonography, so they are more into doing transvaginal sonography, and that gets adenomyosis caught very easily.
Okay. Right. Aditi madam, my question is that.
Good evening, sir.
Right. Good evening.
Good evening to everyone.
Yeah. So what is the acceptance of the modern modalities like LNG IUS in your practice? Okay, what was previous and what is now? The LNG IUS. What is the acceptance?
Sir, where I'm practicing in Javra, it is close to Ratlam, a very small place. So I've been telling patients to go for LNG IUS, but they are not going for it. Basically, at my place, as Jodha sir was earlier saying that in the periphery still they are being treated by quacks and they're taking progesterones on and off. So most of the patients here, I have my stock of Mirena has expired. Let me tell you. Yes. So basically here when I tell the patient, they're very practically speaking. So when I tell the patient you have to go for a device which has to be inserted in your uterus, so they take it like property, upar chala jayega, niche chala jayega. So they prefer going for a hysterectomy here at periphery basically. But at Ratlam, Dr. Dolly Mehra ma'am has used a lot of LNG IUS devices, close to 100.
I think we'll go with your presentation, which you shared with me, because this is a big file with the videos. So it is not going through the mail as well.
I will share my presentation.
Yeah, you shared that. I don't know why it is showing white board.
Now is it okay?
Yeah, sure.
Yes, sir. Perfect.
Okay. So, Madam, may I request you to go ahead?
Yes. All right. So, thank you very much, Dr. Monica and the entire team for having us, and the Corona team for organizing this webinar. Very nice lectures that we have had. And now we are coming to another challenge. And what are challenges are making our life interesting? And when we cross over that challenge, we overcome that challenge, we really feel that we have succeeded and we have given something back to the society. So that is how we are, yeah. So you can keep changing
Right.
this.
So what we feel is that whenever we are dealing any problem, then the three things come in our mind. What is the peers observation? What are the evidences and what are the guidelines? And moreover, as sir was pointing out, yes, the experience, because it matters a lot. Because not always the guidelines, they may be pertaining to the particular area. So there can be a problem of ethnicity, there can be the problem of genetics, there can be a problem of geographical variation. So even the experience, the evidence guideline and all, they should take into consideration. Over to you.
So, yes. So, before we start, I think we will welcome our panelists, Dr. Rashmi Kahar, Dr. Sujit Kondkar, Dr. Renu Setia, Dr. Aditi Rathore, Dr. Shabana Sultan, Dr. Monica Singh, Dr. Sunita Wadhwani, Dr. Darshan Wadekar, Dr. B.S. Jodha, and Dr. Bajrang Lal sir. So I think all of them are very, very senior. Many of them are HODs of the government medical colleges. So thank you very much for being here. And first of all, we are discussing about AUB, abnormal uterine bleeding. So first thing I would like to ask, anyone can answer, how do you define or what is the palm coin classification, FIGO classification of AUB? Anybody can answer the question or we can discuss it and take it forward. All this was in my slides, but unfortunately those slides are not seen. So that is why I will be asking of the slides. So when I talk about, yes, sure.
Coin classification is usually the reason for AUB. The abnormal uterine bleeding is increase in uterine bleeding or increased duration of bleeding or maybe increase shorter cycles. And according to the short form of PALM is structural defects which leads to AUB, and coin would be the non-structural reasons for AUB. The first part would be the PALM, that would be the polyp, that is P. A is for adenomyosis, L is for leiomyomas, and M would be for malignancies. All these are the structural reasons which are responsible for AUB. And the non-structural ones would be, that is the coin. C stands for your coagulation profile. O stands for ovarian reasons of AUB, the bleeding disorders related to ovaries. Then E would be standing for endometrial reasons of AUB. Then again, I would be iatrogenic reasons like copper T or maybe some other drugs which are being given, warfarin or something, which would lead to abnormal bleedings. And N would be non-specific, in which the AV malformations kind of pictures would be coming in.
Excellent. I mean, I think that's a good learning take-home message also for the students because they need to learn all these classifications. We can go to the next slide now. Correct?
Right. So let us start with the cases. So my first case is she's a 46-year-old male and she comes with heavy and painful periods. But as Sarah said, they were at home, and so she has complaints, all these complaints since last 2 years. Her cycles are, she's bleeding for 5 to 6 days, and she has polymenorrhea, maybe by 18 to 23 days. Now her hemoglobin is 9, vitals are stable, and weight is 70 kg. And when we did the sonography, we found that uterus is uniformly enlarged, almost a size of 10, 7 into 6. And then myometrium shows the motile inhomogeneous texture with small cystic spaces. Endometrium is shaggy, 9 mm. Right ovary has small hemorrhagic cyst, and rest is normal. So this is somehow the picture. We can say the diagrammatic, and this is actual sonography, which showed that distorted uterine cavity, and this is something area. So our diagnosis is, of course, adenomyosis. Yes. Now, what further investigations we should do? Anybody can take the question. Dr. Sunita, madam, please.
Yeah, first is history taking. Proper history taking is a must, sir, in any AUB. And after history taking, in history we have to have particular questions, like if they had some PPH in the future, some surgical bleeds, some gum bleeds, bruises, or anything. All those things should come. Specific questions should come in the history, and then we should, after taking history, we should do a proper examination of that patient. Proper examination. Every patient should be done a PS and PV examination. That should be a gold standard while examining a patient. And after that, we ask them for various blood investigations and the sonography, the screening test for what is the reason for AUB. To start with, I would definitely do the blood investigation, which would show us what is the hemoglobin of the patient, what is BT, CT, PT, INR of the patient, and then I would go for sonography.
Anybody?
Right. So here we have done the sonography, we have done the blood investigations. Now diagnosis is in front of you.
So would
Now,
anybody also go for the thyroid profile for the patient?
Yes,
yes,
yes, ma'am.
Right. Because again, that is very important. Minu madam has said that because the hypothyroidism, again, not only in pregnancy, but overall the incidence of hypothyroidism is increased. And maybe it has different geographical variations. But if you see in Maharashtra, it is 20 to 22%. If you see in Telangana or in Jammu Kashmir, it is going up to more than 35%. So she is very right that we have to have that thyroid profile as well. Yes. Now the diagnosis is very clear that patient is having adenomyosis. We all know the etiopathogenesis and all. So how to manage this case? Because we have done the endometrial aspiration and it has shows that there is a secretory endometrium. So what is your impression now and how will you manage the case? Aditi madam.
Yes, so because now the patient is 46 years of age, so I would like to start her on maybe progesterones first and foremost. So after doing all the initial investigations, maybe progesterones, or we can start with NSAIDs or COCs also. But I would like to, because she's 46 years of age, I'll put her on a short trial for progesterones, or maybe I would like to take her on mifepristone also. And if as we earlier discussed, the choice according to these days is LNIGUS, so I might even ask her for Mirena, but I can give her options. Basically, she will fall into a medical management category, and initially, but the patient has to be counseled first that these are your symptoms and these are the features. So first of all, I will offer her medical management, which will relate to her symptoms, which is pain and bleeding. So if she first, I'll put her on, in my practice, I'll put her on a short course of progesterones, advise her that she might go for LNG IUS if she wants to. Though in my and basically in my practice, I am going with mifepristone or Lloyd 25 milligram per day for 6 months.
Right. Okay. So madam has pointed out about medical management. Minu madam, what we would like to add regarding the mifepristone?
I think, what you, Dr. Aditi, whatever you said, I think it fits very well for the patient's management. I would also go for something similar, but we can also give the options to the patient. Sometimes we may miss a small little polyp sitting there, so maybe a good either scanning or an office hysteroscopy, probably.
Yes, ma'am. I would like to add that though we have done a sonography, but the diagnostic modality of choice is basically MRI. Basically, what I've read. Though I've never done basically it should be done. And yes, of course, as ma'am has said, office hysteroscopy rule out any other polyp and
तो छोटा पॉलिप रहेगा, ऑफिस हिस्टोस्कोपी करके उसको निकाल दिया. ये एडिनोमायोसिस कैन कॉज मेनोरेजिया, बट इफ शी आल्सो हैज डिस्मेनोरिया, इफ शी आल्सो हैज डिस्पेरुनिया, generally history of previous curetages, adenomyosis earlier we used to think is seen more in Paris women as compared to endometriosis, which is seen in infertility women. But nowadays we are seeing a lot of adenomyosis even in infertility patients. So we have to keep this even at this thing in mind. However, because she is already para 2 and she's 46 years of age, and we can see an adenomyosis there in the uterus. I think progesterone management is a good option, or a Mirena seems like a hysteroscopy followed by Mirena. Seems like a good option to be given to the patient.
Patient who is already 46 years of age with the abnormal uterine bleeding she has reported, it is first to do the endometrial biopsy. Whatever may be the reason, we have to, beyond 40 years of age with abnormal uterine bleeding, it is the protocol to follow. And if endometrial biopsy, you have a choice of hysteroscopic guided, then it is better. You can diagnose and take a sample, or at least you had excluded by the secretory endometrium that already has been done. So you have excluded the endometrial disease, and now the choice is mostly nowadays we are preferring to give the LNG IUS for these patients, and they are responding very well to these, and we have prevented many hysterectomies these patients.
Can I add something, ma'am?
So I think, yes, Monica, madam.
What I wanted to just comment on MRI. MRI would definitely not be the line of investigation you would suggest, because of just, upfront, because a 3D USG, sections in a 3D, which is available nowadays to most of the good machines, gives us a pretty accurate estimation of the adenomyoma, the location. And just yesterday, I was seeing a patient with gross adenomyosis. I was teaching to one of my students, and as soon as I went to the right ovary, there was a huge endometrioma also. So this was in a 42-year-old woman. So that endometrioma was sitting along with the huge adenomyoma. So sometimes, just giving time to a good scan, like it was told in Prashant sir's lecture, we have to give time to our machine. The machine has not got to be an ornament in our hospital. It has to be used effectively, and it can reveal so many things. MRI is basically for fibroid mapping, for those cases where you're planning a surgery, you want to know where to put your incision. And one more practical thing I was just going to speak about. One of my patients with gross adenomyosis, where I tried putting LNG IUS, she had a very much, increased UCL, and I had difficulty putting the this thing, Mirena, and I had to remove it after a year because she did not stop bleeding. There were patches of endometrium which that LNG was not able to release enough of progesterone to control the bleeding. Ultimately, she went for a MAP hysterectomy.
Right. So till now, I can enumerate the very good take-home messages which were given by all expert panelists. Number one, that per speculum and per vaginal examination is a must, which the youngsters now day by day they are actually not doing, and they are directly going for TVS and whatnot investigations. So that is a one first take-home message. Second take-home message, that as sir has rightly said, that because she is near towards the perimenopause, so endometrial aspiration, biopsy or sampling, that is must. And what Dr. Minu has added very well, that hysteroscopy guided if we do, then definitely the sensitivity and the specificity of our diagnosis will increase. And along with that, if we go ahead with the LNG IUS, then probably it is a best method. But only the concern what Dr. Monica has shown, that is absolutely right. So it is again, there was a very good study which has shown that if we give a trial of levonorgestrel for 1 month prior the LNG IUS, and if we are successful enough to see that whether the bleeding goes down, then probably Mirena or the LNG IUS will act better. So I think these are the take-home messages which till now we have got. Now I can ask Dr. Rar sir.
Another
Yes,
point
ma'am.
I would like to add here, since it is a FOXY meeting, and FOXY has given good practice clinical guidelines.
Guidelines.
In that, they have very clearly mentioned. Thank you, Monica, for asking me to read those guidelines. More than 40 years of age, all patients with AUB and endometrial biopsy should be done, like Sir said, Jodha Sir said. Less than 40 years, you should do an endometrial biopsy if she is at high risk. She's obese, she's hypertensive, she has been having PCO, or she has a family history of any malignancies, CA breast, CA endometrium, CA ovary, CA colon. So all these patients should undergo even under the age of 40 years, they should undergo. These are the good practice clinical guidelines by Foxy. So that is, I wanted to point out.
Right. So may I ask Dr. Rar sir, Dr. B.L. Rar sir, that what is about the mifepristone, because much was said, and though it is not yet come into the recommendations, can we use mifepristone in such patients? Will it help in adenomyosis? B.L. Rar sir. Is sir here?
Yes, it can help in adenomyosis, and we are working in government setting, है ना? So
Okay.
there is we cannot prescribe drugs from outside. So we cannot use these two drugs. We have only drugs which are available in a hospital. We can prescribe only these drugs.
Right. So public and private, there can be the difference. Yes, Monica Gupta, madam, can you comment on that? Mifepristone, what is the usage and is
Monica
it?
We are using
Monica
mifepristone mainly for the fibroids right
Okay.
now, because in the fibroid we are getting a very good result, and
Right.
moreover it is going to give a amenorrhea for 3 months. So it is
Absolutely.
going to help in adenomyosis also, and many a time both of them coexist, adenomyosis with fibroid, so we can get the result. And whatever we are giving we have to suppress the estrogen receptors. So I think it is going to help it out. But for the adenomyosis, we are using the Dynogest mainly. Both are working on the same point, creating an amenorrhea and decreasing the size of adenoma.
So anybody using letrozole, Dr. Monica Singh? Anybody using letrozole? A lot of publications have come now, 5 milligram daily letrozole for 3 months.
Letrozole I have not used, madam, but there was a very good study which stated the reduction in the uterine size. Actually, we're not discussing fibroid here, but in a patient with myomas, if you give a patient 3 months course of letrozole vis-a-vis 3 months course of ulipristal versus mifepristone, the reduction in the fibroid volume, the size, was greater with ulipristal. But because of the side effects, it has gone into disrepute. I think the biggest being the hepatic. Ma'am, letrozole, I don't have first-hand experience, but I really want to start it because of the volume of cases we are doing. And all these therapies are actually just to buy time, either before surgery or for the anemia to improve or for the hemoglobin levels to rise or before the patient makes up a mind for surgery. They are not definitive therapies, or for a perimenopausal patient to go into menopause. Even that transition period can be covered by mifepristone, letrozole, or ulipristal.
Fantastic. But that line was very fantastic. You said that this medical management is, yes, really it is not definitive. And really we have to have some time, and that's why we are using it. It is absolutely right. So now we will move to this conservative surgical treatment. Suppose the patient has not responded to the medical management, and or the adenomyosis is very huge. So in which cases we should go for debulking or cytoreductive surgeries?
I had put nice pictures of this in my presentation.
That's why actually Dr. Menu Madam has a very good video of laparoscopy on this. Unfortunately,
Unfortunately, but
yes.
I will share it with you at in some other webinar, no problem.
Yeah. So anybody can put a focus on this debulking or cytoreductive surgeries where they are required in adenomyosis, and does it really help? Anybody can put.
The patient who is already 46 years of age, and our aim is not to do the debulking. If she has completed all the family or obstetric area of her, then these procedures may be avoided if possible. If patient wants to conjure her uterus and suffering from this disease, then these can be tried, and they are very effective because it is sometimes the localized adenomyoma. If you resect it out and the results are good in best hands, where you can repair the uterine wall, or you can oppose the uterine wall properly with the stitching if possible, or various techniques which are available to remove the most of the adenomyotic tissue, the patient's response are good.
In our area, patients are, before they come to our hospital, they have already consulted at least 10 non-medical people and got their sonography read by them and Googled it. And they don't want to ask you what treatment are you supposed to give. They just come and tell you that ab ye ho gaya hai and this is not going to improve. That is what we know. And ab bahut time nahi waste karna hai. We want a hysterectomy. And if they convince them that hysterectomy is not the only thing that can be done, we have many more things to do, they would go to somebody nearby and do their hysterectomy and they would come to you and aapko nahi aati thi isliye aapne nahi kiya. That is what they do.
But this is the challenge for us. We are not biased with these people who come and say, do the hysterectomy. We have to avoid it because the patient who is adenomyosis, if the patient is having adenomyosis and if we are able to keep that patient with you for next 6 months with LNG IUS system, I can say that at least 50% of patients will be with good results with 6 months of LNG IUS system itself only. Whatever may be the cause of it, it may be a fibroid, a small fibroid, maybe adenomyosis, it may be only ovulatory dysfunction. So this system has changed the scenario in last 15 years where we are using this system and getting good results of it and avoiding hysterectomy.
So,
Aditi
but for
madam,
conservative surgeries, we have to take the consent for hysterectomy also. If it is not, if anything happens, so then patient says, "Ki ma'am, when you have to do a hysterectomy, you do it right away because she is already 46, completed a family, and going for a conservative surgery, opening up everything. If you are doing a laparoscopy, also you can go for a laparoscopic hysterectomy and all because convincing for the medical management is easier because we can say we are going to save your uterus. But when we are going for the conservative surgery in the patient who has already completed the family, I think it's very difficult because whenever you are operating, you have to take the consent for hysterectomy. And then she says, कि मैडम जब आपको hysterectomy ही करनी है, तो why don't you do directly? Why are you going for the conservative surgery first and then going for the hysterectomy?
True. I mean, that is a practical problem.
Yeah, Dr. Monica, I think we both of us totally agree with you. Conservative surgery probably will be a good option where the patient wants to retain her reproductive function or she is very, very clear that she wants her menstruation to continue. She does not want a hysterectomy at all. So those are, I think, will be reserved only for those patients. If she's finished her family and nothing else is working, rather than a conservative surgical management, I think a TLH is much faster, much easier to do as compared to the debulking surgery. I agree with you on this.
And here, here again, I would like to give the message that thank you very much, the Public Awareness Committee. We have great work that we have to do a lot of work on LNG IUS and to remove the myths and the misconceptions. And we should thank Dr. Priyankur and Dr. Monica Umardan as well for arranging this. And Dr. Aditya, I think whenever we'll come in that area, we will do some public awareness program because this is, I think, required because you said very sadly that my stock of the LNG IUS has expired.
Yes, sir. I've offered free of cost also. I've told patients I'll not charge anything. You get it.
If anytime such situations arises, you can
Ma'am, I just disagree. Many of the
LNG, I will put it.
Patients, if we counsel properly, even I am working in a small city, Alwar, near in the Rajasthan, and we are little bit backward in everything, but the people are accepting it. Today only I have inserted one Mirena, and within a month I insert 2 or 3 Mirena per month because you have to counsel them. Instead of taking medicines for so long, you have to spend so much of the money on coming and going and spending on the medicines and taking the medicine regularly. Why not you just insert a Mirena? It will hardly cost you 5,000 rupees and everything will be, many things will be taken care of. And people are opting for it. I think counseling is very important from the part of the doctor.
No, we are agreeing, madam.
Yes,
but,
ma'am.
at the same time, the practical, yes. Practically, at many places, what Madam Aditi has said, in many places, madam, there are myths. Okay, whenever we put something inside the uterus, it may pierce and it may, because I have done personally one study, and that study was called as T. T means she. Okay. So what we have done, we have gone to the lady and we have asked you who told you that this will cause a problem. She said she has told me. So tell her name.
Actually, ma'am, Alwar is a very big city. Where I am working, it is a small tehsil. Alwar is not a small place. Alwar is a big place. So we are where we are working, it is a tehsil place. It's actually a very small.
But ma'am, you try, you will definitely
I
get
have my stock
succeeded.
ready here in my OPD. I can show you the stock with me. They're not, maybe the fault lies with the doctor, but what they believe, as Madam Wadhwani just said, they prefer getting a hysterectomy done. You refuse them because it is very easy to discuss. As Sir Gorak said, public awareness is a must. It is very easy when we have the guidelines, as we will discuss HIFU and uterine artery embolization. But it is patients think hardly 20-25,000 rupees. There's a hub here, but where they get hysterectomies done for 20,000 rupees. So they would prefer going there and getting a hysterectomy done rather than bearing the cost of all the drugs. And because the Asha Karyakarta is a male culprit aajkal to khair वैसे, but all said and done, I understand the counseling has to be done. The fault lies with the doctor, and I'll try harder.
Ma'am, when we started our practice, a government delivery was very a rare thing. People used to say, why we have to come for a normal delivery in the hospital. Now the scenario has changed because of the awareness. And when we all will work together, we all
And when
will say the same thing.
the government
patient
sector will endorse LNG-IUS, then only it will work. The government
Ma'am,
sector
they are giving LNG-IUS in Rajasthan. Even they are coming in the government supply also. So the scenario will change. Definitely, we have to work hard for it.
Yes, we have to work hard, and I can give here assurance because myself and Dr. Meenu Agarwal, we both are here the candidates for the vice president of the Foxy next year. And I think we should take this. No, that's why I said candidates, and I think our motto actually is the same because we are both are not politically and something, but yes, really we want to work something, and my motto is to have the medico legally correct gynecologist, and second is we should say no to the unnecessary hysterectomies. So if with this motto we together all work, definitely yes. So we are going towards the case 2. May I request Meenu madam to conduct this case?
So she's a 58 years old lady, complains of some spotting 3 days ago, menopause at the age of 50 years. Earlier cycles were regular. She's had para 2 last delivery 26 years ago. She does not have any hypertension, diabetes, no history of tuberculosis. There is no, her thyroids are normal. No family history of any malignancy. She is mildly paler. PP is okay, normal. Weight 65 kilos. Per speculum done normal. Per vaginum PV done normal. Breasts are normal. There is no evidence of any vaginitis on per speculum. What next will you do? Yeah. Dr. Jodha, sir.
The patient who is having menopause at 50 and come with any sorts of spotting or bleeding, we have to look for what can be the possible causes. So the PS has excluded many things, whether it is estrogen deficiency, vaginitis, or cervicitis. So the next step is to do the imaging, and at least a transvaginal sonography will tell us what is the endometrial thickness there, what is the ecotexture in the endometrial cavity, or any sort of, or in adnexa, if we find any type of cyst formation. Sometimes these patients in postmenopausal age group has cyst formation that secretes the estrogen that can proliferate the endometrium and can cause endometrial proliferation or thickening, and sometimes these bleeding may be there. So these are the patients who requires endometrial aspiration first and exclude the cause, and if possible, then it will be better to do hysteroscopic examination in this endocervical canal, and then uterine cavity can be judged, and that will help and guide us, because these are the patients where the risk of malignancies is to be considered. If a postmenopausal patient gets bleeding, we have to exclude these things.
Right. Sir, as you have said rightly, we have done the TVS. It has showed the normal uterus. Endometrium was 5 mm. Both ovaries normal, no cyst, no fluid, no tenderness. Even as you said, endometrial biopsy was also done with hysteroscopy guide, and it showed there was normal, no focal lesion, and it was atrophic endometrium. Now, how we should proceed?
In fact, now there are some publications, very strong evidence that if your endometrial thickness is less than 5 millimeters in a postmenopausal bleeding, you may not do an endometrial biopsy, and you can straight away consider it as an atrophic right, and then treat her with low dose estrogen or whatever you want to do.
So now we have come to the conclusion that this is a case of atrophic endometrium.
vaginitis.
And now how we should proceed? May I request Dr. Monica Gupta, madam?
So just we have to give her some reassurance because the patient is in very much a panic state because she has got bleeding after 8 years and simple tranexamic acid to stop the bleeding. Estrogen creams can be started if there's another problems like atrophic vaginitis and all. And we have to really follow up the patient because at that time the endometrium thickness is not there. And many times many of the food materials are also having estrogens. So even after eating those, the patient can have bleeding. I have seen so many patients who are having postmenopausal bleeding and nothing comes out after the investigations. So
Absolutely,
we have to
madam.
ask her to come after 6 weeks.
Right. Absolutely. So as was Dr. Jodha sir was saying, this is a chart. This is how he has even said when initially the office endometrial biopsy, as madam has rightly said, when it is less than 4 mm or 5 mm, there is no need of hysteroscopy. And if bleeding resolves, there is no problem. But if does not, then yes, we have to give her reassurance and some the estrogen therapy. And as in previous lecture, Dr. Madam she has very clearly given the message that full-blown 0.625 EE is not required, and CA is not required, and even the half dose will work and will not cause any cancerous lesions, but still it will take care of the bones there. So here also, even with that half dosages, the many a times this atrophic endometrium gets cured. What is your experience about the estrogen and which estrogen should be used? What should be the use? What should be the dose? And what should be the route? Which estrogen, dose, and
Dr.
the route?
BL, sir?
BL, sir.
Okay, it's not. Dr. Sunit, Dr. Aditi, you want to say, comment on which estrogen will you use?
Ma'am, I use conjugated estrogen because that is not very potent. And normally, initially in such a woman, I would like to give local application in the form of cream. And I would like her to ask her to take it continuously for 10 days and then maybe twice a week for 3 months. And as ma'am has rightly said, he call her for follow-up. One thing I would like to add is that we should see for any local, though it was mentioned, hysteroscopy, no focal lesion seen, but even a vaginoscopically because post-coital bleeding, some local because the vagina is very thinned out. So sometimes the cause of bleeding might be urinary or some local lesion also. And unnecessarily the patient is panicking that it is in post-endometrial bleeding or so that is very important in this set of women that you have to have a proper examination locally. Is there urethral caruncle? Is there bleeding from some local spot? Has she hurt herself during coitus? And sometimes the patient doesn't give the proper history also because of embarrassment or something because this age group they would not like to discuss it. This is very important because otherwise everything is normal in this female as the case has been discussed other than atrophic endometritis.
Very, very good take-home message. I think a good per speculum examination, and sometimes there can be local bleeding because of atrophic vaginitis also. They can have the bleeding.
Here I would like to just mention a case, madam. There was a 5 years back in the institute, somebody put the what we do the for
Speculum.
collapse. They have put the
ring.
Yes, pessary was put. But that woman was almost 56 to 57 year, and later on, she had a big trouble of the erosions of the vaginal cavity, and because of this, and that was a case of atrophic endometrium with prolapse and then really that pessary causes a lot of trouble to that.
Ulcerative lesion.
So I think Madam has said very good take-home message. Thorough per speculum examination of the vulva, and then yes, we should go ahead with that. So we have talked about type of estrogen, dose, route. Any role of add-back therapy here?
No, sir. Not in postmenopausal age group.
There is.
Yes.
That will
So,
be, if we are treating a fibroid, maybe with some kind of a leuproid, GnRH agonist, then we can talk about the add-back.
So that's a very good message because many a
Add-back
times what
therapy,
happens.
can I add something?
Yes, madam, please.
Basically, add-back therapy, sir, is for those cases where there is a profound suppression of the estrogen levels, hypoestrogenic state, almost always due to a long depot preparation of agonist, which will suppress the HPO axis, and that is where you require add-back of estrogen, progesterone, tibolone, etc. But for natural menopause of 8 years duration in a woman with this sort of atrophic endometrium, I don't think an add-back therapy would help.
It is a
But
normal
it's
nutritional
better,
advice which will be
it's
helpful.
better if she is given calcium,
Yeah, but
and hematinics, calcium, B complex, vitamin D. That way, and life, and a little bit of exercise, whatever she can do, weight management, orthopedic support. That would be more important to her.
So good take-home
Madam,
message.
what should be?
Case.
Absolutely.
Very low dose estrogen can be given to the patient, like conjugated estrogens, Dr. Monica mentioned, or even, estradiol valerate, just 1 milligram a day, or half a tablet of 0.625 premarin. Or oral estrogen creams can be given, especially for urinary complaints. They many a times also have urinary complaints along with the spotting or postmenopausal spotting. So that you don't need to add progesterone in these cases. When you are giving very low doses of estrogen, just a nice follow-up. We should not think that this patient will have endometrial hyperplasia and she will have malignancy. So you can just give very low doses of estrogen, just monitor her, and slowly then you taper it down and then stop it. So that should be the way to go.
Sunita, madam, what diet will you advise? Specifically because the madam was mentioning regarding the estrogen-rich diet, because there are some things which are available there. So what diet will we advise in these patients? Estrogen-rich diet, what we usually...
The soybean is considered as estrogen rich, sir.
Isoflavone rich.
Isoflavone in the soybean.
Right. So here I would like to add.
We have to take care of the calcium and vitamin D, vitamin D and the micro and macronutrients in the diet also.
Correct.
And with the
Just
fiber,
like
plenty of water.
Sir, we should also do PT-CT, PT-INR for this patient, because in a dengue period or some other period, there can be some coagulation disorders which can be responsible for this spotting. Because I have one patient who is quite old and she has dengue, and she was admitted with my husband. I mean, like, he's an intensivist, and she started having vaginal bleeding. And everybody was not worried about her platelet count, but her family was worried about her vaginal bleeding.
Absolutely.
And what we did a CBC for her, and her platelet count was around 15,000. And that was the reason. And it was difficult to convince them that that is the reason. They were all worried about that. CA to nahi ho gaya. At the age of 62, somebody is having bleeding period.
Correct. Absolutely. Last question. That what should be our coital advice in such couples about the coitus? Whether we should tell them to avoid, or whether we should tell them to have the good coitus.
Can I answer, sir?
Yes, please.
I was a part of sexual medicine committee for a long time with Dr. Neeraj. So I took part as faculty in many of these webinars, wherein there is no need for her to shun coitus at this age, or because of the spotting. She has to be reassured again. Because very many times the partner comes with the spouse comes with the patient to your consulting. So he also has to be reassured that this is something which has to be just taken with calmness and complacency, and they can use liberally the lubricants and the jellies. Sometimes these women are not aware that such products are easily available. I was just looking through on Amazon for my patients, and I saw a plethora of products with all side effects, with customer ratings very much within reach. Now, one patient wanted a particular brand which was available only from US, and this brand is being shipped by Amazon from US in 10 days. So she got that also. So it's like the patient just has to be told about these lubricants and jellies, because all said and done, the vagina is very thin. There will be reduced sex drive. There will be the spotting might cause her to be, depressed. So they have to be reassured and encouraged to have a normal relationship physically.
Absolutely. In fact, it has shown that the sexual intercourse, it improves the pelvic blood flows. And
Yes.
that's why we have to even tell them. In fact, in Dr. Prabhu has to say, he used to say that it is a servicing of the vagina. And that's why in perimenopausal age, in fact, we encourage them. But as you have rightly said, with the lubricants, with the proper precautions, we should tell them that yes, they should go ahead with the coitus. Anybody would like to add? Or we should go to the last case.
Yes.
Right. Minna, please.
So she is a 39-year-old lady, para 2, living 2, one abortion, previous to LACS. She comes with menorrhagia and dysmenorrhea. LMP is 34 days before. She's had a history of a previous surgery for incisional hernia. She's pale. On PV, her uterus is 14 to 16 week size. What next? Dr. Monica Gupta or Dr. Aditi Rathore, you tell what next?
Ma'am, I would take her history, proper history, and then I'll do her urine pregnancy test to rule out pregnancy, as her LMP was 34 days back. And as the slide is itself showing that the differential diagnosis, you have to take a history of, I'll do a proper per speculum and pelvic examination, which has been mentioned is 14 to 16 weeks, then go for a sonography. And in the ultrasound, we rule out it because size is 16 weeks, so it can be either adenomyosis or a leiomyoma. So, or there might be some aneuploidy bleeding, and then come to the diagnosis. Most probably, as a case is suggesting, it could be her UPT was negative, as it's saying in the ultrasound, revealed fibroid uterus, and hemoglobin was 8.6 gram. So, she first of all, she has to be hemodynamically stable, and her her blood counts have to be corrected. Her hemoglobin has to be improved. So either iron sucrose or FCM has to be given, and then the fibroid, the decision has to be taken for the fibroid. Basically.
You want to add something to it?
Yes,
And we have to see what is the size of the fibroid and where is the positioning of the fibroid, because these all things are very important. If the fibroid is subserosal, we are not supposed to do anything. If it is encroaching into the endometrium or into the myometrium, half of it in the myometrium or half of it in the endometrium, then we have to go for something like that. And when the size is around 14 to 16 weeks, it means it's a very big fibroid. So the medical management is not going to help much into it. And I think the surgical treatment should be the better option for this patient. Either we go for the myomectomy or
Can I add something?
Yes, Dr. Monica, please.
Yeah, this patient walks into my OPD. I see that she's pale. I see the history 34 days back. Straight away, take a urine sample, take a blood for CBC if you have pathology there, and take her for a good transvaginal, transabdominal sonography. Things will be sorted out. You rule out pregnancy on the table where you're doing the pregnancy test. You will get hemoglobin in 1 hour or 2 hours. And third thing, as soon as you enter the uterus, do a transvaginal. If she is empty bladder, you will see whether it's a fibroid, adenomyoma, whatever. So it is a one-stop, like a one-stop fertility clinic. This is a one-stop diagnosis. So within the next 3-4 hours, madam, we should be able to give a diagnosis and proposed plan of management to this patient.
Totally agree with you. This is how we also function at our center. we have a lab, we have an
Because,
ultrasound.
ma'am, nowadays there is no surety the patient is going to come back the next day. तो जो करना है
Practically, we have to
Yeah.
do that. Absolutely,
Today,
absolutely.
from one end to coming to now the metro, they can come faster. It takes 1 hour for them to come for the next visit.
Ma'am, they are so restless. Nowadays, patients are so restless for diagnosis and management. They've lost that patience, They've lost that, faith in the doctor that they want everything fast, fast, fast. So
And then 1 hour of counseling. After everything is done,
Right.
45 minutes.
After
to
that,
1 hour
they'll
of
Google
counseling.
everything and ask you cross questions also.
Right. So just for discussion, not in this case, but what are the indications of the medical management in fibroids? Which drugs are really efficacious and especially in perimenopausal patients? Anybody can take this question.
So the size of the fibroid should be less than 4 centimeter, and the fibroid should, for medical management, it should not be indenting. Mainly, the size should be less than 4 centimeters. The patient should have completed a family. She should, mother the patient. If the size is small and the patient is not desirous, or if she has not completed a family, so maybe we should go for medical management. And the drug of choice nowadays, mifepristone is recommended, 25 milligram per day. And if the fibroid is not indenting the cavity, we can go for LNG IUS also. So these are the main 2 drugs which can be given for medical management, and then you can give GnRH agonist also.
I think the position of the fibroid is
Yes,
also
ma'am.
important.
medical
Yes.
management is definitely not recommended for 0, 1.
Yeah.
And sometimes even for 2, because you have to, these are intracavitary, so they will cause some problem or the other for the patient. Yeah, that patient has to be counseled.
It should not be indenting the cavity at all.
0, 1, 2, if present, should be managed by surgical way only.
Category
But
4 to 6 are basically for medical management. Basically.
Yeah. Basically, for medical management, best would be 3, 4, and sometimes 5 also.
So
0, 1
Figo
and 2 are not to be done.
Yeah, 0 and 1 is definitely
1 and maybe 2. This is what I think is the take-home message, that Figo 0, Figo 1, and maybe Figo 2 should be surgically managed. Figo 2, if it is a larger sized fibroid, but you still want to do it hysteroscopically, even 1, you can then give GnRH, shrink the size of the fibroid, and then go for a hysteroscopic myomectomy. For Figo 0, you can also use tissue retrieval systems like Bugatti shaver and remove those fibroids. But others, intramural fibroid, I think what take-home message is that we can go for a medical management. It's a good option.
Right.
Gaurav, you want to add something?
I will just read here Foxy GCPR guidelines for the fibroids, and they are the same, that the intramural or subserosal myomas grade 2 to 6, initially for the management tranexamic acid, COCs, NSAIDs, LNG, IUS, and if treatment fails, myomectomy depending upon location. So even here again in these guidelines, the importance to the location is being given. In women more than 40 years of the age, where fertility is not desired, for small fibroids, medical management, where size is less than 4 to 5 centimeter, followed by hysterectomy. Short-term management up to 6 months with GnRH agonist with ADVAC, followed by myomectomy. Long-term management is LNG IUS, and newer medical options like the uripistol acetate or low-dose mifepristone, they are given. But here I would like to raise a question to you all, that is really uripistol effective?
One
Or
thing I would like
mifepristone
to
is
add
effective?
here, Gorak, one thing I would like to add, it is for the doctors who are attending. Whenever you want to use agonist, and if it does not work, you would go for a surgery. So if you're going in for a laparoscopic surgery, suppose a 5 centimeters intramural fibroid, then it is better not to use an agonist, because even if it becomes becomes smaller, you don't get good planes on laparoscopy. Agonist is very good for submucous fibroid, where it is slightly larger then you would like to tackle with hysteroscope. There to reduce the size, using leupride is a good option. But something which you can do laparoscopically and you want to reduce the size, there leupride is not so good, because you will not get the planes at all. It gets very fibrous and it gets very difficult to remove laparoscopically. So
Absolutely,
this
that is a very good take-home message that one should understand where we want to preserve the fertility. We want to go for laparoscopic myomectomy. Ideally, the agonist should not be used because again it will distort the planes. And yes, that's a very great option. Now my question is, Ulipristol or mifepristol? Why? When? Sunita madam, what is better in your practice? What is your observation, experience?
Misoprostol, I think, is better
Mifepristol,
because
sorry.
mifepristol would be better.
It will be better. Any other? Anybody can comment on this? Aditi madam?
Mifepristone is a
Mifepristone
cheaper
has better
option.
liver profile, cheaper, and then you don't have to go for regular liver profile also, because unipristol is slightly hepatotoxic, but you have to go very stringently for a regular liver checkup. And mifepristone is cheaper, easily available, and I would not say it reduces the size of fibroid in my practice. Basically, it helps abating in the symptoms. So in a smaller fibroid, in a matlab where you can give a trial with mifepristone when the cavity is not indented, the patient is only having menorrhagia, and she really, I have found it very useful in my practice. And basically, I found it useful in patients who are near perimenopausal. Basically, in 6 months, 7 months, 8 months or year, they attain their menopause, and the fibroids then gradually shrinks.
Sir, Rar sir, Dr. B.L. Rar sir, you have said that yes, in government practice these drugs are not available, and absolutely right. But sir, in such cases where what will be the option? What is the better thing for the medical management of fibroids? What do you do in the government practice? Jodha sir?
Sir has left, I think. He had left a message.
Yes,
Gupta madam?
So we can just give some hormones to them. Simple progesterone or COCs can be given, because whatever we are having in the government setup, we have to use them only, or or we can just tell them, we don't give in their writing, there are some other drugs also. If you want to have, you have got an options also. You can go to, well, we can refer to our private practitioners or other doctors, and we can at least counsel them if the other options are available. But because we are not having these drugs over there, so we are only supposed to give these only drugs to you.
But is this a law that Dr. Monica Gupta?
Yeah, ma'am, this is a law. Well, if you write something which is not available in the government, you have to, they make a real fuss out of it, and they make the doctor, they make a complaint against the doctor that they are writing the drug outside for some other benefits. They don't think it is a beneficial for the patient. They think it is a beneficial for the doctor to write a drug which is not available in the government setup.
Right. So I think again that is an organizational point. We have got that the essential drugs, many essential drugs, which should be available in the government sector, because they are not there, we are not able to give the justice to our patients. So I think we should
Sir,
take
I think
cognizance.
it also differs from state to state, because what Rajasthan esteemed doctors are telling us, it is like, I think, peculiar to Rajasthan. In Madhya Pradesh, the government is very government doctor friendly. In fact, too friendly to them. So left and right, they are writing medicines in the private sector, even for C-sections. If medicines are not available, patient is getting from outside. Mirena, they are getting from outside and getting inserted. So over here, there are no legal hassles like in Rajasthan. What I've noticed in my state, because we are very friendly with the government sector, because we are in Bhopal Obsgyne Society, there is a close network of government doctors and private sector.
No, because why I raise this question, because again we are discussing on the platform of the FOXY and especially of the Public Awareness Committee. So I think we all should help us together, and interstate what is going on we should know. So great. I think rest of the states like Rajasthan, Maharashtra, I think we have to work on the line what MP is doing.
Yeah, I think Maharashtra is also liberal, Meenu ma'am. Maharashtra is also quite liberal.
It is liberal.
But not
And
in
in
all
Rajasthan was the
sectors.
first state to impose the RTI, right to health. Means
Yes.
every doctor has to do a free treatment if, what is the definition of emergency? Nobody knows. So if a patient says, I don't have a money, you have to treat the patient. And how it is possible? How you can insert Mirana to every patient free of cost? Even you have to purchase the Mirana by yourself. So there are many hassles, and we have to make a path in between.
Yeah, I think
Dr. Gorak, myself, right?
private
Dr.
practice.
Gorak, please listen to me.
Somewhere you mentioned.
I will request the Foxy to provide all these drugs in government supply, like Marina, like Unipristol, like Mifestone, so we can treat the patient better. We are short of all these drugs. Although we have asked the government to supply the Marina and all these drugs, but still they are not available because government says you have to take the minimum drugs which is essential, because there are many drugs which can treat this AUB, many drugs which can treat the fibroid and the adenomyosis. So these 2-3 drugs, there's progesterone, COCs, these you can use, and if not, then you do the hysterectomy. So
a very good suggestion, BL sir.
A very good suggestion, and definitely we will try to take this message to the office of the Foxy, so that something can be done, that in some states where these things are not available, so how there is the essentiality of these medicines, that definitely as an organization we can tell to the government health sector, and
because
definitely
we are for the betterment of the patient, and what is the role, because we are learning new things, but the things the drugs come in the government facility after 10 to 15 years. Still we are on the stage 1, progesterone 1 and 2, only those.
Yes.
Only the last year, because of our recommendation, the dydrogesterone is supplied now, 2 years back. Dydrogesterone and natural progesterone.
Great.
In last
I
2-3
think
years.
that slowly things will change.
And we are prescribing these in gunny bags to the patients. Actually.
Anna, but sir, as you have rightly said, we should, as an organization, definitely we should go to the governments and we should go ahead. So last slide and last question of this today's panel is, yes, now everything was not helpful, and now we have taken the decision of hysterectomy. So when to take such decision, and which route and why? Whether it should be abdominal, vaginal, LAVH, or total laparoscopic hysterectomy, what guidelines says and what is the practical. Everybody should, I think, answer one by one.
Sir, I think whatever the route the surgeon is comfortable with, is a
The skill of
confident in
the
doing the
patient,
things.
surgeon is responsible for that.
For
The skill,
absolutely.
and availability of laparoscope is again a thing.
If the doctor is very competent, he can do a lap hysterectomy in any of the case with the previous 2 cesarean, a big uterus and fibroids or adenomyosis, endometriosis. But everybody is not that expert. So whatever your efficiency is there, in your expertise, you have to choose the method accordingly.
Right. Sunita madam, the patient has come to you
with our expertise, we have to see what the patient also needs. And if we are not expert enough, we should refer the patient to the expert then.
Great. So
that
means
also one.
fantastic.
So saying that patient, what surgery patient goes through will depend on which OPD he walks into. 1, 2, 3, 4 surgeons are sitting, and even in Ruby Hall, we say the same thing. Like, goes to Meenu, madam, OPD will go for a laparoscopy, go to this person's OPD will go for a vaginal. So it actually patient's luck also sometimes.
Sometimes, yes, absolutely. Yeah, that was I was going to say. Sunita madam, you remember that even in some units, we were being trained to do the vaginal hysterectomy till 16 to 18 weeks fibroid.
Yes.
Right?
We have
Even
done.
yes,
We have been doing.
done.
Even in Ratlam also we are doing. One of the surgeon is there. He's an expert in vaginal surgery. He comes over and he takes over the surgery of 16 weeks uterus also very comfortably.
Even I have done the non-descent hysterectomy up to the even up to 14 to 16 weeks.
Absolutely. So I think why we put this slide, the reason was that it is not like that the laparoscopy is something great, but even other methods like the vaginal hysterectomy, even as Madam has said, the non-descent vaginal hysterectomy with the coring and slowly taking out the fibroid, definitely it is helpful. Only thing is the first answer by Monica Gupta madam was very right, that whatever the surgeon is comfortable. But again, I will add Aditi madam's sentence that the patient should be fully convinced with this method, and then with thorough discussion, with thorough consent. We have to tell them these are the alternatives, these are the benefits, these are the problems, these are the expertise, these are the costs involved, these are the days of admission involved, and depending upon that, we have to take
I
the
would
decision.
also like to add one more thing here. Since it is a fibroid uterus, she is around 50 or whatever, 50 plus years of age. We have to keep in mind the possibility of a sarcomatous change in the fibroid, LDH levels, MRI if required, and no morcellation if you have a little doubt also that it could be sarcomatous. So those are the patients where we should go for an open surgery, or even vaginal is fine, but no, or morcellation in the back. So these things should be kept in mind and should be told to the patient when we are dealing with these patients.
Absolutely. Though there was a good paper by Singh et al., and the Singh said that the incidence of sarcomatous change in fibroid is 0.01%.
Used to be, not anymore.
Yes. But still, as what Madam has said, is right, very right, that the days have gone. Just to take one paper and comment on it, we have to keep in the mind, and with slightest doubt, at least what Madam has said, those precautions we must take in our practice. So the take-home messages by everybody, one by one, regarding the management of AUB in perimenopausal age group. We'll start with Dr. Sunita, then Dr. Monica Singh, Madam, Monica Gupta.
First thing I would say is proper history taking is a must, and proper examination of patient, including the PS and PV examination of the patient. That should be a compulsory thing whenever you are dealing with anything. Even if the patient is bleeding, you should do a PS for her.
Absolutely. Dr. Gupta.
So I want to just comment that whenever we are taking the history, the patient is already taking treatment from one or the two other doctors. We should know what treatment she is taking and whether she is taking it regularly or not. Many times I have come across the patient who are taking OCs very irregularly. Whenever they feel like, they take it, and whenever they don't feel like, they stop it. And that is the major reason for the menorrhagia in most of the patient. So we have to keep a very good eye on that, what type of medicine she has taken and for how long, and whether it was a very regular one or not.
Yes, Dr. B.L. Rarse.
So after taking proper history examination, we have to counsel the patient. The counseling of the patient is the best, whether we treat her medically or surgically, because counseling what she wants. So it is better to counsel the patient, or because now I am retired from government service, so I counsel every patient of perimenopausal bleeding, and most of them, they have accepted that please give me medical treatment. And I assure, still medical treatment is the best. And as you say, vaginal hysterectomy, abdominal hysterectomy, laparoscopic hysterectomy, still we senior doctors are best to like the abdominal hysterectomy, because these everything is in front of our eyes, and because of the good antibiotic era, there is no any difference in infection rate.
Okay, Dr. Monica Singh, madam.
I feel that palm coin classification everybody should have in their minds. Not to be means it should be just imprinted in your head. Number one. Number two, FIGO classification of fibroid should be in your subconscious. Classify immediately. Number three, every gynecologist should be perfect in her TBS examination.
Great.
See, when I was
Last,
a
Dr. Aditya.
chairperson for Imaging Science Committee, this was my advocacy that every gynecologist should be able to do a basic gynecological ultrasound and should be able to at least read and do a basic anti-scan.
Madam,
So,
I think you only have taught me because,
right. So
because I attended your Foxy FMFI course.
oh yes, we did
So
those
I
courses.
was a very sincere student of FMF UK, FMF India, then Dr. Suresh sir, everywhere I was there.
Dr. Aditi, and then we'll conclude the session.
I think everything has been all the take homes have been given. I think we have to be thorough in our examination of the patient. We should not jump to conclusions. The perimenopausal is the age group where the borderline is thin between sarcomatous tumor, the malignancy, and benign lesions. So we should always keep in mind that our investigation should be thorough and proper use of sonography and everything should be done. And the patient and medical management should be the mainstay. We should not jump to unnecessary hysterectomies. And I would just like to say, because this is a public awareness meeting also, one of my colleagues is facing inquiry by the collector recently only. I cannot name her, but she did a hysterectomy in a hospital owned by a quack, basically a BHMS. So he admitted the patient and he asked her for a hysterectomy, and the consent was taken and the hysterectomy was done. And now the patient put an allegation that she was having some urinary problems, because the thorough history has to be important. So she was having some urinary complaints, hysterectomy was, and mild adenomyosis was shown in the scan, which was done somewhere, and hysterectomy was done. The patient is 42 years of age. She has a 12-year-old child. So now the collector, the single line the collector has asked, whether the treatment given was in lines of the diagnosis made. So the diagnosis was cystitis and mild adenomyosis. The treatment done was hysterectomy. So therefore, we should always go for medical management first. Write it down on a piece of paper. The patient is advised for medical management, and then only the surgical management should be offered.
So thank you very much, all panelists. I think it was a very great discussion, because many a times what happens is we take too many cases and we discuss many whatnot things. But I think each point, each case was discussed very well. So we are very much thankful. I am very much thankful to Dr. Meenu madam as well, because she has given many insights. I thank Dr. Monika Umbardan madam for inviting us, though it was a last minute invitation, but really we enjoyed this. And I thank Dr. Priyankur Roy and all Foxy members, all my panelists, chairpersons. And thank you very much. And we must say thank you to Corona, because again, yes, such webinars are needed. Not always the product oriented webinars should be done, but these are very fruitful discussions and the fantastic. I am very much thankful and I am happy. Over to you, Dr. Meenu madam.
Thank you, Gorakh sir. Oh, yes, ma'am. Yes,
Thank you.
ma'am.
Thank you,
You are a
ma'am.
very,
Thank
very
you,
good
Gorakh sir. Thank you,
moderator with
Shatabdi.
me.
Thank you, Monica.
Thank you, all the panelists. It was a very nice blend of people who are in private practice as well as people who are in government sector. So we could get the insight from both the angles and we could understand, how to manage these patients. So very, very good take-home messages, I think, from all the panelists were fantabulous. Everybody gave a very, very good take-home points. And I'm sure the people who have attended this particular webinar have enjoyed it. And thank you, Corona team. Thank you, Priyankur. I don't see him. Thank you, Monica. Thank you, Satabdi, for nice introductions. And thank you, everyone here. Thank you.
Ma'am, before Shatabdi gives the official vote of thanks, I would like to also thank Gorakh sir for chipping in at the last moment. Actually, this panel was supposed to be taken by Madhuri ma'am, but because she was traveling to a meeting in Hyderabad, she couldn't join in. Gorakh sir, thank you so much for accepting our invitation and being there at the last minute as a savior. Meenu ma'am, you have done a complete justice to the topic in spite of not being a forte for you. Ma'am, definitely when we have any fetal medicine program or any imaging endoscopy program, I will always invite you again, ma'am.
Thank you.
Thank you all.
Thank you very much.
Yes.
Wishing everybody a very happy Diwali.
Happy
Diwali to you as well.
Thank you. Same to you.
Thank you. See you
Diwali
again
to
till the next webinar.
Good
Yes,
night.
thank you all.
Bye, webinar.
We should meet up.
Sure, ma'am.
Yes, thank you.
Thank you, ma'am. Good night, everyone. Thank you so much. Thank you, Abhishek, for being
Thank
the
you, ma'am.
technical support. Thank you, Corona.
Thank you so much, ma'am.
Good night.
Monica, ma'am, thank you.